extension tomograms, and those that did not reduce on flexion extension, they considered irreducible. Obviously, this protocol led to many morbid transoral surgeries. The next conceptual shift occurred in the 1990s, where surgeons realized that the instability is the primary driver of the pathology and not the compression. One of the most famous papers to come out of India was the Goel-Lahiri C1-C2 fixation method, and this was a significant improvement over the 1987 technique of transarticular screws, which could only be used in reducible dislocations. Goel was also the first to propose this concept that instability is the issue, and he proved that in a series of papers. He showed that many cases improved without the need for anterior surgery. The modern era was ushered in the last 25 years, and it is a matter of pride that this is mainly by Indian surgeons. A paradigm shift in thinking took place when surgeons started to realign the craniocervical deformity to achieve decompression. The focus shifted to facet joints, and again the pioneer idea was by Dr. Goel, who described the distraction with spacers and the C1-C2 cages. And this was improved upon by Dr. Sarat Chandra using reduction maneuvers, joint remodeling, and extra-articular distraction techniques. But the posterior approach is not the only way. Various surgeons have proposed a facet joint release from the anterior approach. Chow Wong from China and Dr. Lahiri from Mumbai is a big proponent of anterior release, as also Dr. Patkar from Pune. As you can see, the focus has shifted to the facet joints, release them, and align the deformity. As we get better than at manipulating the facet joints, most pathologies have become reducible after joint manipulation. In 2015, Menezes published an update to his famous algorithm, and note that the reducibility criteria now he added traction under anesthesia. The algorithm still proposes anterior decompression for those that are irreducible on traction. So a lot of surgeons still end up doing transoral odontoid resections. The techniques have evolved to use endoscopic transoral surgery. However, many Indian authors have published extensively that these can be aligned with joint release and facet distraction. So in summary, a paradigm shift has occurred in our understanding of these deformities. The initial concept was to treat the compression, and then implants got better and we were better able to provide stability. And finally, now we aim to realign the deformity to achieve decompression. The concept of an irreducible deformity is being questioned. With that general background, let's look at how to logically approach various craniovertebral anomalies. There are just too many of them. And this article by Pang classified them as malformations of the central pillar, which usually cause instability, and malformations of the surrounding two rings, the foramen magnum and the Seaman ring, which usually cause compression. But I like to view craniovertebral pathologies through a biomechanical lens rather than a pathological one. We all know that the clinical features often are a result of one of three biomechanical abnormalities we see in this region, namely instability, deformity, and spinal cord compression. And patients usually have a combination of these three. Down syndrome is an example of instability. There is no deformity there. Congenital basilar invagination is an example of a deformity. There may be associated instability, but predominantly this is a deformity issue. Achondroplasia with foramen magnum stenosis or Seaman arch anomalies is an example of spinal cord compression. And this situation is rare, as most pathologies will cause spinal cord compression as a result of either instability or deformity or both. So whenever I see a craniovertebral problem, I try to think which of the three biomechanical issues need to be addressed when treating a particular problem. As a bird's eye view, the management strategies for each biomechanical problem can be summarized like this. For instability diagnosed on dynamic imaging, the treatment is to stabilize. For deformity, the distortion of the bony anatomy is best judged on a fine-cut CT, and the primary treatment strategy is to reduce. And for isolated compression as seen on MRI, the treatment is decompression. So instability in Down syndrome requires stabilization, deformity in congenital basal and invagination requires a reduction, TRE malformation without any instability, pure stenosis requires decompression. That is debatable, but this is one of the classic example of just stenosis. This is an example of posterior C1 arch anomaly causing compression. So coming to imaging of patients with predominantly an instability issue, the investigation is some kind of dynamic imaging, commonly X-rays. But sometimes in small kids with dysplasia, it is difficult to judge X-rays for instability, so a dynamic MRI is useful in those situations. For imaging of a craniovertebral deformity, the deformity has to be closely looked at using a fine-cut CT. We use multiplanar formatting of DICOM images to understand cross-sectional anatomy, and also 3D modeling software like 3D Slicer to simulate screw trajectories. Frequently, we get 3D printing bone models made for judging anatomy in these complex deformities. We look closely at the lateral pillars. Those are the major weight-bearing columns, and they have to be either destroyed or deformed to cause a deformity. We measure the amount of distortion of these joints by using the sagittal joint inclination angle as proposed by Dr. Sarat Chandra. It is the inclination of the C1 C2 joint with respect to the posterior aspect of the odontoid process. We also look at the craniomedullary angle and the clival canal angle, and our goal of surgery is to restore this to an obtuse 135° plus angle. We also like the PBC2 measurement, which tells you how much of the odontoid is behind the line joining the basion B with the posterior inferior corner of C2. And our reduction goal is to reduce this to less than 9 millimeters. In the coronal plane and the axial plane, it is also important to assess the rotational component of the deformity. The next step is to evaluate the reducibility if the patient has a deformity that is not correctable on dynamic imaging. For that, we use an intraoperative traction under general anesthesia with full muscle paralysis to assess the reducibility. We have used weights up to 1/4 of the body weight of the patient for about 15 to 20 minutes to judge how much the C2 reduces from its vertically translocated position. Some deformities, in spite of sustained traction, will not show reduction or will have a partial reduction. Those we classify as quotes irreducible. And when I mean irreducible, I mean that we anticipate some extra surgery like a release procedure that is going to be required to make it reducible. And the way we identify this is we see the relationship of the odontoid with respect to the clival line. And this is easy to identify and can be used as a proxy for determining where the basion is. If the odontoid tip is above this line, then a release procedure is going to be required. Coming to treatment strategies. Those patients with a predominantly instability issue that is apparent on dynamic imaging, which reduces on extension, requires a stabilization procedure. So this is easy. He is a Down syndrome kid with C1, C2 and OC1 instability. Occipitocervical fixation and fusion has been done. This is a Morkoi child, can't see clearly if there is instability on X-rays. Dynamic MRI shows instability, gets an occipitocervical fusion. Os odontoideum, instability issue only, C1, C2 fusion. On the other side, there are deformities that do not reduce on dynamic imaging. For those, a CT scan will show the status of the lateral pillars and the facet joints. The ones without a facet fusion, which are usually in the 99% of the cases, we will use intraoperative traction under anesthesia in the OR. Those that reduce on traction are treated with posterior fixation without a release, and those that cannot be reduced will require a release procedure. Example of a reducible deformity, flexion extension, no reduction, but traction X-ray shows that the odontoid is coming down significantly. No release procedure has been done. The reduction is on the implants and traction as described by Dr. Abumi. and this is the post-operative MRI. For those so-called irreducible deformities which do not reduce on traction in the OR, there are two options for facet release for making an irreducible deformity reducible: a posterior release or an anterior release. And I think there is a place for both these procedures, and the way we decide which one to use is by looking carefully at the C1 C2 joints. This is what was proposed by Dr. Sarat Chandra. Less than 100-degree joint inclination, do a DCER procedure, which is distraction, compression, extension, reduction. At 100-160 degree, this needs some kind of joint remodeling to drill the facets to make them parallel so that you can do a DCER. And in more than 160-degree angle, which are the joints so vertical that the distraction is extra-articular. It is between the C2 and the occiput, because there is no way to distract between a vertical C1, C2 joint. And these cutoffs are not absolute, as they also depend on the surgeon's experience in manipulating these joints. And personally, I find the vertical joints very difficult to treat using extra-articular distraction, and this technique is not reproducible every time. So my preference is, if the sagittal joint inclination is less than 100 degrees, then I would choose a posterior distraction technique, works quite well, easily reproducible. If the angles are between 100 and 160 degrees, then I think it depends on a lot of other factors, and this is a bit of a gray area. Expert surgeons will be able to achieve good results with posterior only approach, but when the sagittal joint inclination approaches 60 degree and above, I think I am in favor of an anterior release procedure rather than a posterior, just because it is so much more reproducible and predictable to have that reduction in our hands. This is an example. You can see a partial reduction using DCAR for a case with a sagittal joint inclination of 178 degrees. This is from the paper by Dr. Sarat Chandra. For these situations, we currently prefer an anterior release, as we doubt the ability of extra-articular distraction of the joint to correct a deformity to a satisfactory extent. And this, mind you, is a very, very technically difficult operation, while anterior release is not only technically less demanding, but a perfect realignment is almost reassured. If the sagittal joint inclination is less than 100, in this kind of an example, relatively easy joint distraction, spacer, OC1 or OC fusion or C1 C2 fusion, whatever floats your boat, results are usually good and reproducible. But when the angle is almost vertical, that's a problem. In these situations, we do a transoral or a retropharyngeal anterior release followed by posterior instrumentation. And in this, what we are doing is releasing the contracted anterior structure, the longus colli, capitis, the capsule, the facetal adhesions from the anterior approach, and then turning the patient prone for a posterior fixation. So this is an example of almost vertical joint with a perfect realignment post and anterior release. This is another example. The odontoid process is anteriorly curved. So we did an anterior release, removed a part of the C1 assimilated arch so that the odontoid can move into that position to get a perfect alignment. And over a period of time, the odontoid fuses with the clivus many times. This was not intentional, but we have found that many times that anterior column also fuses odontoid with the clivus, like you can see in this case as well. This is a 17-year-old boy, Klippel-Feil syndrome, myelopathy. You can see the position of the odontoid with respect to the clival line, which is drawn in red. The first photograph is the traction before the release. You can see under traction, the odontoid is still not moving below the clival line. After the release, you can see the odontoid has moved down in the prone position. That's how the odontoid is with respect to the clival line. And when you do a posterior approach, thumb pressure behind the whole odontoid moves forward. And this is the kind of reduction you can get by doing an anterior release, a complete reduction, a complete realignment of the funnel, as Dr. Lahiri likes to call it. the lateral facet joints, you can see the amount of distraction and the release that you have achieved by just doing an anterior release. Now, the third group, now you have a deformity, but the CT shows fused C1, C2 joints, or this patient or a patient that has been previously operated by someone and that person has fixed the patient in a dislocated position, or a deformity like this, platybasia, dense curved posteriorly. There is no instability, but only way to get a decompression in such a patient is a transoral odontoid resection. This is another example of a basilar invagination fixed in an irreducible, in a dislocated position from the posterior approach. There is no way to realign this after this patient deteriorated a few years after the surgery and then required a transoral odontoid resection, a massive operation and not a perfect result. This is another case, 10-year-old female. You can see the lateral facet joints almost vertical with a bad basilar invagination. Unfortunately, patient has been fixed in this position by a posterior fusion. Now, these patients are very tricky to do a posterior surgery for realignment. A posterior foramen magnum decompression is not going to decompress the spinal cord because the spinal cord is tented over that anterior odontoid, and many times the surgery becomes a transoral resection. However, in some situations, this is an exceptional situation where we encountered one case which had kind of a fixation done in an irreduced position or a malaligned position, but it was only 3 months and he deteriorated after surgery. There was no implant loosening or anything, but the patient was fixed in a dislocated position. So what we did is the first stage, removed the implant from posterior, took down the posterior fusion mass, whatever it had occurred. The facet joints were not fused. So we flipped the patient anteriorly, did an anterior release, and then turned the patient back again posteriorly to do a posterior realignment procedure. We were able to avoid a transoral odontoid resection in this patient about 3-4 months after the index operation. So this is also possible. So in conclusion, for the CVJ pathologies and management strategies, look at each problem from a biomechanical viewpoint. For instabilities, the treatment is stabilization. For deformities, it is a reduction. For compressions, isolated compressions are quite rare. So just decompressions are usually not the common surgeries for craniovertebral problems. So-called irreducible deformities can be reduced with some kind of an anterior release, either anterior and posterior. We decide a posterior release usually for the lower sagittal joint inclination deformities, but an anterior release followed by posterior fixation for those with a high sagittal joint inclination angle. Thank you very much.
Thank you, Dr. Kshitij sir. It was a great talk on the algorithms for CVJ deformities. Any questions? We have a question from Rakesh Lohana, sir.
Hi, Kshitij. Excellent talk. Two questions. So, anterior release, when would you do retropharyngeal release versus when would you do transoral release?
So the usual default is a transoral release because most people can open their mouth. The transoral is a more direct approach. It's like a tonsillectomy operation, or an adenoid operation. It's a very quick operation. Retropharyngeal approach we use only for patients who have a poor mouth opening. So if their mouth opens less than 2-finger breadth, then it's going to be tough to do a transoral release. Although there are some published reports which have used an endoscopic release, endoscope assisted release in patients who have a less mouth opening. So that again becomes very minimally invasive without doing an upper cervical approach. The problem with the retropharyngeal approach is that one is you get a scar on your neck. The other is you are retracting all those viscera of the pharynx and everything. So postoperative dysphagia is a problem. You can get hypoglossal nerve palsies and facial nerve palsies at high up. And we have had patients with these kind of palsies with a high cervical approach. So unless it forces us to do a retropharyngeal, we would do transoral is our default.
Yeah, thank you.
And many people choose retropharyngeal because they think that transoral gives rise to more infections. Remember that the transoral is a soft tissue operation. We are not putting any implants through the mouth. So I kind of say it's like an equivalent to an adenoidectomy in children or a tonsillectomy, a posterior pharyngeal short procedure. So the posterior wall heals very fast. So that's the difference.
Thank you. And the posterior fixation extent, whether you do transoral release versus posterior cage fixation, spacer, would it be different? You would go long segment if you do transoral release?
No, not necessary. So in both situations, whether you're doing an anterior release followed by posterior or just posterior, the biomechanical thing that is needs stabilization is the same.
So OC2
Correct?
in all
Because
cases.
you are correcting all cases.
OC2,
So
don't go below
it
subaxial.
is OC2. No. It is not a C1, C2 in most situations. That is because we are correcting a deformity. So a deformity release requires an odontoid that needs to be translated out of the foramen magnum. The amount of cantilever force that you can apply to longer rods is much more than what you can do with short fixations. I know that some people do short fixations and rely on the manipulation of the facet joints. That is a good procedure for sort of the grade ones that I showed. The sagittal joint inclination is less than 100 degree. You are going to get a good facetal release. The joints are almost parallel. There you can do a C1, C2 and get away because it's manipulating, distracting the facet joints that is resulting in the reduction. But when the joints are extremely vertical, then distracting the facet joints with some kind of an implant or something, it's quite hard. You don't get those implants there in those paddle shavers are all inside because they are all vertical. So then you are relying on your external rods and everything to correct. So in those cases, we require the longer rods and the occipitocervical. Same concept proposed by Dr. Saraj Chandra. Exactly the reason why he does occipitocervicals, because he is using the implants to do the distraction, compression, extension, and all those kind of maneuvers to get it right. So the C1, C2 fixations are, usually the very low grade joint inclinations.
Okay, thank you.
Kshitij, thank you for coming, and it has been a wonderful and excellent talk as expected.
Thank you, Ajay.
As
Thank you.
expected. We are not as fabulous and wonderful surgeon as you are, because you do it very fabulously and you have been with certain pioneers, so your understanding about the topic is too high and you have practiced it in that way, in the elegant way only. But what we as practitioners have done is suboptimal than this, and still we feel that the clinical results are not greatly different. Yes, it has improved by our stabilization procedure and definitely better than what we were doing 15 years back. But still, the extensiveness which with this algorithm is described, does it need in all case, and does it reflect with the clinical outcome? I'm not saying the radiological or the fusion part.
Yeah. So I'll give you the answer which is given by Dr. Lahiri to this kind of a question. All right, because this has been asked before, and Dr. Lahiri responded this way that, the problem with compression that develops is that, yes, I agree with you that if you get a partial reduction and stabilization, patients will recover. But we have seen a lot of people deteriorate years down the line. So the case that I showed towards the end, that happened later because the patient recovered initially, and then deteriorated later. So that's one problem that happens. The second problem that happens is partial recovery. So, you know, you have a quadriparetic patient not ambulant at all, and then over a period of time recovers, starts walking, but it's still spastic and, you know, has not, it's still some residual problem. So now at that point, your question in your mind is that residual thing because spinal cord is still stretched over the odontoid, or is it an inherent problem with the spinal cord? The cord is permanently damaged or not? So that's the another reason. The third reason is basically literature, you know. So when literature, you look at literature, all the parts measurement, amount of encroachment of the odontoid to the foramen magnum. So more than a centimeter encroachments are this is more of a neurosurgical concept.
So for the lack of time, the end of the
Nene, free Zoom છે ને એટલે પાછો કરો જોઈન કરશે ને so good a discussion time. It has been a wonderful lecture. Why?
But we'll have to tell him. We'll have to.
Yeah, we'll just call him, na?
Zoom ના કારણે Zoom નું જે વર્ઝન છે ને એમાં જાતે કટકી જાય.
ફ્રી ઝૂમ હતા એટલા માટે.
આવે છે ઓછો છે વધારે હલો 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 બરોબર.
Hello. Hello. Yeah.
Sorry, we lost your connection, Kshitij. We were listening to your answer and you just neurosurgical point of view and further.
Okay. Okay. So should I answer or?
Yes, you should.
Oh, okay. Oh, yeah. So the last point is about restoring the CSF flow dynamics around the craniovertebral area, and Dr. Lahiri calls it like restoring the funnel. So you know that posterior fossa to the cervical spine looks like a funnel, and you want to restore that funnel because not only there is spinal cord there, the CSF flow dynamics around that craniovertebral area is also an important factor, especially people who have syrinx and Chiaris and other things. So we have had recently one patient who, you know, after initial improvement has deteriorated after 3 years. You know, so he still has that anterior compression. When we did the CSF flow studies, which we can do CSF flow studies on MRIs, it shows that the fluid movement around the craniovertebral area is affected because of that narrowing down in that region. So there are several reasons, but I can understand where you are, what you are saying. I would only suggest that, you know, for the deformity patients, you know, look at the sagittal joint inclination, and if the sagittal joint inclination is vertical 160-degree plus, remember that you are treating a spondyloptosis. Okay, so if you are not someone who is used to treating a grade 5 spondyloptosis in the L5S1 area, please don't try to attempt that at the craniovertebral area, and you know, with the intention that I'll get partial and fix it, because that lands you up with a bigger problem, you know. So those partial things and posterior reductions, even if you get partials, are okay for the sort of grade 3, grade 4 listhesis, if you want to like compare them with L5S1 spondylolisthesis, where your sagittal inclination is not that very high. Now this cutoff is, you know, surgeon dependent, because you know, somebody who is extremely expert will be able to reduce a 160-degree, 70-degree angle also, but an average person will find it very difficult to go beyond your line of sight in the joints to do any kind of joint manipulation. So I think risk stratify your cases. The ones which are really severe, those ones do not equate them that all basilar invaginations would be similar. So that's how I kind of would put that answer to that question.
Now I am pretty convinced with the answer and taken back by the question which I asked. But at the same time, I will agree with you on this ground also that when we were doing anterior surgeries for fractures, it had got an excellent outcome with certain morbidities. We had found certain recoveries which were not assumed or may not happen. That is what was thought, and it had been given results at 3 months, 6 months late presented patients also post-traumatic. The same thing holds here, because we are now going completely for posterior surgeries in fracture spines usually, and that is the same ground that holds for, because a static recovery or a no recovery, what is holding back that recovery we don't know.
Right. So I agree with you. Most patients would be treated with posterior, and that's what I do most of the time. The anteriors are the ones for these special situations, you know. So the problem with the craniovertebral area is that everybody tends to look at the problem in a very similar kind of a lens. It's basilar invagination, it's basilar invagination. You have to manipulate the joints no matter what, how the joints are shaped, you know. So there are many factors that will come into play when you are trying to do that. And one of the biggest factors is the surgeon's comfort in doing that. It's not the same across the spectrum. So that's how I would kind of say that these are special situations, the extreme other end of the deformity cases.
Thank you so much, sir. That was a wonderful talk. We'll move on to the next speaker now. Dr. Sai Dilip sir will be speaking about monoportal foramen magnum decompression.
Good evening, friends. I'm Dr. Sai Dilip Viswanatha, Chief Consultant Head of Spine Surgery, Ayushman Super Specialty Hospital, Visakhapatnam. Today, thank you for the wonderful opportunity to speak in such a prestigious forum about craniovertebral junction anomalies and full endoscopic solutions. Today, my topic is about foramen magnum decompression and how it's going to change in the outcomes with the use of an endoscope, and my preferential scope is a monoportal scope. As you all know, CRE1 malformation with syringomyelia, its full endoscopic posterior fossa decompression is my presentation. You know what are the two types of the CRE malformations. One is the type 1, where downward placement of the cerebellar tonsilate, whereas the type 2 with tactile plate deformation, and also the placement of the cerebellar brainstem at the fourth ventricle. So CRE malformation, it occurs when the cerebellum extends into the spinal cord, putting pressure on the brainstem and the spinal cord. So patients usually presentation in the early childhood or between 41 to 46. Complaints of headache, neck pain, dizziness, numbness or tingling in the arms or legs, difficulty swallowing and walking. The key historical development of foramen magnum decompression is started from Choudhary original description of the malformation in 1900 and Dandy Walker introduction of posterior fossa decompression. In 1990s, advance in imaging, surgical techniques and instrumentation. So the conclusion, foramen magnum decompression has evolved significantly over the past century with ongoing refinements in surgical technique and instrumentation. If there are no tonsillar herniation up to C2, there is no role of making C1, C2 fixation or spacers. Plain foramen magnum decompression is acceptable. So treatment options, yes, we should try the conservative. The surgical decompression is relief of the pressure on the brain and the spinal cord. So surgical options, either open FMD or a endoscopic surgery. So there were multiple studies to prove that symptomatic improvement of the patients for 82% of patients experiments improved in symptoms of headache, neck pain and sensory deficits. Even the syringe reduction was 70% patients were shown. The complication rate is 11% with CSF leak, which we can take in with the endoscope. So what we try to do? We try to do a C1 docking or a subhospital docking and start removing the C1 arch and block and also do a subhospital craniectomy. So creating enough space for the cord to bulge back. This is the position which you usually follow for the C1 arch and the foramen magnum decompression. So you can see that after the C1 arch removal, you can reach the subhospital area.
Foramen magnum decompression, C1 band.
This is the hospital area. This is C1 band.
Complete laminectomy and decompression.
And after C1 arch, the dura is pulsed. Even the C1 band has been removed with the endoscope. This is after decompression. This is the hospital area where you have done the subhospital craniectomy, usually 2 into 2 size.
Subhospital craniectomy done, bilateral cord decompression done, brainstem decompression done.
You can see the pulsed dura. This is the C1 arch.
And C1 arch.
And this is the pulsed dura with bilateral decompression.
And you can see both bilateral.
So this is a case of patient with the complaints of syrinx, and you can see immediate post-operative there is improvement of cord around the CSF is very much visible, and the mobilization is very faster. The patients are usually mobilized the next day. So usually I try to use a smaller scope, 5.7 mm working channel with 8.4 outer diameter, only gravity assisted, normotensive G and prone position. Usually systems are foramen magnum decompression, C1 arch posterior decompression and band excision at the CV junction. So enlarging the system magna is based on the premise the CSF pulsation and enlarged system magna will promote ascent of the cerebellar tonsils as well as aid in the propagation of CSF pulsations into the spinal subarachnoid space. And this is the scar of the patient after the decompression. This is a small video how we do it to dock. This video is not clear. I will try to show the next video. So this is the subhospital craniectomy done. So bilateral dura visible.
Now the 12 o'clock is cranial and 6 o'clock is caudal. That is the right side. And this is the.
And up to the inferior part of the C1, the cord is been free without destruction of the facets. So what about the tonsillar herniation if there a herniation is there? So we can do something called full endoscopic posterior fossa decompression. We try to clear the occipital bone. Try to do the occipital craniectomy. Create a gutter of 22, then start opening up the dura. You try to remove the arachnoid membranes and see the tonsillar herniation. You can use a RF cautery to just distinct the tonsillar herniation. Those cases I try to use a Duragen or a Lyofen implant. Now we are able to achieve monoportal dural closure with suturing technique and the endoscopic clips. So the study of 13 consecutive patients, the patients improved about 12 patients. The complication rate was a small leak which improved conservatively. So also the advantage of endoscopic decompression has been, systemic review has been there by 17 studies which have proven to be beneficial. The new study is coming from John Hopkins for the foramen magnum decompression, which is going to be the gold standard. So this is an article which is published on the comparative analysis of neuroendocrinic foramen magnum decompression versus traditional open surgery. No wound complication, the suture removed at post-op day, the patient come to improvement of symptoms. So these are the conclusion. Full endoscopy approach is the alternative way of surgical management to the benefits of early discharge. Long-term results and multiple studies are required. These are the various references. We have done one more case of a patient of foramen magnum decompression. In Uzbekistan, the patient has improved immediately post-operative. So how we do the C1 arch? You can see the compression of the C1 arch, the position, docking. We try to do something called bilateral gutter technique, land on the spinous process, remove the lamina bilaterally and remove and block. So you can see the gutter for the spinal canal. This is after the decompression.
Odontoid fracture,
You can see the well decompressed
compression,
dura, pulsatile dura.
of quadriparsis. So we have done C1 in.
You can see the C1 arch pin is being removed and blocked. This will prevent the complication of the neural injuries since we are not going to give traction injury to the cord. You can see immediately post-operative the cord can be decompressed. So thank you for the opportunity. A teacher affects eternity. He can never stop where his influence stops. Thank you very much.
Thank you, sir. Any questions from the panelists or the audience?
Yeah, excellent talk. It requires a lot of guts to handle CV junction cases with endoscope. Regarding the last case you showed, it's a C1, C2 instability, where you took out posterior arch of C1. The patient has likelihood of worsening after surgery. Did you fix it or just?
And we have an anterior fixation.
Sorry,
the anterior atlant hospital fixation has been done.
Oh, okay.
So we were talking about only removing the C1 arch and block.
Okay, yeah, thank you.
The advantage of using a Carrison punch in C1 arch is very meticulously done because sometimes your punch starts pushing it on the cord. So the way of removing C1 arch is very much easy. If you do something called bilateral gutter technique, you do bilateral laminotomy remove so that you are trying to be near the spinous process so that the C1 arch can be safely removed without violation of the facial joints or not violating toward the emissary veins.
Yeah, thank you. Any questions? Yeah. Thank you so much, Dr. Saidlip.
Next presentation is also mine.
So our next topic is also by Dr. Sai Dilip sir, who will be talking on endoscopic assisted transarticular screw placement.
Good afternoon, everyone. Nice to talk to the great forum again. Today we'll talk about endoscopic C1, C2 fixation or fusion. So ultimately, what we want is fusion in few of the cases where, because we worry about C1, C2 fusion, because of the high riding vertebral artery on the accuracy and safety of C2 pedicle screw, placement in basilar imagination related risk factors. So influence of variations of CV junction anomaly on safe C1 lateral mask and C2 pedicle screw insertion, there is a multiple studies. Why it is considered risky? Because of the critical neurovascular structures, vertebral artery, inferior cerebral artery, spinal cord, C2, anatomical variability, biomechanical demands 50% cervical rotation, difficult surgical exposure and severe consequences. Other people are killing it, but why we want to take it forward? So understand who and what to treat the knowing alternatives. Dr. Goel, Dr. Haram's, and Goel Haram's technique is considered one of the safest technique for C1, C2 fixation. So coming about C1 to fixation fusion, we should discuss about the pathology, what is about the reduction, the anatomical landmarks, the vertebral artery anatomy, and the bone quality. So these are the various studies which show the incidental finding in patients of the vertebral artery anomalies. So high rating vertebral artery is a preoperative planning of C2 instrumentation based on 908 potential screw insertions. So C1, C2 fixation fusion, there are different types of fixation. There is sparse fixation, there is transpedicular fixation, there is translaminar fixation, and of course transarticular fixation is also considered enough amount of fusion. So my case study is about C1, C2 intraarticular distraction with anti-cervical cages for basilar muscle derailment, the nuances and review of literature. So why endoscopy? Endoscopic already is a approved technique. So full endoscopic anterior odontoid screw fixation, a novel surgical technique, is already been published and we have tried it. Why endo? Posterior percutaneous transarticular standalone screw instrumentation of C1, C2 with endoscopic assistance, a report of key studies, because better surgical visualization, less soft tissue damage, reduced blood loss, lower complication rate, shorter hospital stay, and shorter time to return to work. How do we do it? So this is a case of C2 individual bone cyst. We try to remove the bone cyst and debride the bone joint. Then we start putting the bone graft and fusing a transarticular screws with endoscope. So how do I do it? We take an endoscopic assisted guide wire, transarticular screws and inserted by like AAD screws, which are guide wire mediated. Drilling is done into the pedicle, and over the pedicle, over the guide wire, the screw is inserted under vision. So how we do it? This is a case of a 74-year-old Grisler syndrome, history of diabetes and corticosteroid abuse, severe neck pain after pharyngitis. So diagnosis is C1, C2 instability. Solution, C1, C2 intrafacial debridement and bone grafting, then percutaneous C1, C2 transarticular screw fixation bilaterally under uniportal endoscopic assistance. This is the planning and this is the position. While coming to stage 1, percutaneous transarticular screw endoscopic assisted is done on the right side, fixation is done, drilling is done, then the guide wire is inserted, then the endoscopic vision, the screw is inserted. Straight to left side, but only up to the half. Why? Because we are worried about the vertebral artery anomaly. Debride the facet joint. Insert the guide wire. And start doing the bone grafting of the facetal joint. Definitely you may see the C2 nerve and the vertebral artery. The bone chips are inserted. Then under the visualization C1, C2 left side, the transfacial screw is inserted. The left side fixation is done. The final outcome is a good fusion bed of the C1, C2. You can see it very well. And 4 scars. So the conclusion is, there is no standalone rule for every single case. Understanding the patient's characteristics, mastering the technique and adapting the situation is very important. Thank you very much.
Thank you, sir, once again for an amazing talk on the endoscope, the use of endoscope for assisted screws placement. We have a question from the audience. So
Yeah.
please.
Hi, Dr. Shah, Dr. Jayesh Sardhara here. So,
Yes,
very
sir.
nice.
Hi, sir. How are you?
Good. It's very nice. Good experiment. So, just any transarticular screw, the best prerequisite is it has to be reduced. So, just to be emphasized, it has to be completely reduced. If you don't reduce the C1 and C2, and if you put a transarticular screw, particularly if the vertebral artery is crossing the joint or there is a high riding vertebral artery, there is a highest risk of vertebral artery injury. So it has to be understood that it has to be completely reduced. So the indication of endoscopic assistant C1, C2, whatever you have seen is reducible AD, right? Irreducible
Yes, sir.
AD usually as suggested has to be released under vision, then it has to be reduced, and then you can try the transarticular screw. So I think you are following the same, right? So it's only for reducible AD.
Yes, sir. Yeah, usually this patient is a condition where it's an already reduced joint. So transvestral screws, you are right. Always reducible joint is more safer to not to injure the neurovascular structures, because even the C2 nerve is also towards it. So, but here the advantage of using an endoscope is while we are debriding the joint, we are going to also observe the vasculature, the high riding artery, and we are going in a stepwise manner. So the safety of endoscope here for putting the transarticular screws in normal surgery is fluoroscopic guided. But here endoscopic is your landmark for you to know how much posteriorly you are, how you are entering the C2 parts, and how you are going toward the C1 and not going too anteriorly toward the C1. So mostly we try to avoid it, but it's usually preferential is, that's what we're talking about. There is no basilar invagination. It is a plain C1 C2 instability. What we expect here is the patient's pain relief for the C1 C2 fusion. So definitely it's a reducible joint, sir. Irreducible joint, maybe probably the joint spacer, the same endoscopic assisted way, we can easily put it, because once you see the facet joint, it is more visualized joint for us. So I think maybe next time I should try with you.
Yeah. So, and another point I just want to clarify that what I find in your videos that the good point of monopodal endoscopy, because of water pressure, that venous hemorrhage is less, right? Did you felt that things? The venous hemorrhage which usually seen in the open surgery may be less because of pressure you are using for endoscopy. Is it correct, right?
Yes.
Fine.
Yes, sir. The way of doing intradural or craniovertebral junctions is when you are doing a water-based surgery, the concept is same. So we are always on the center. The chance of going lateral dissection to encounter emissary veins or lot of epidural vessels are quite less, 1 point. And when we are reaching the decompression with the water irrigation will definitely help in preventing the excessive ooze.
Thank you, sir. Thank you.
Thank you, sir. The
Thank you,
next
Jayesh.
talk is by Dr. Satish Rudhrappa, sir, who will be sharing his thoughts on foramen magnum decompression.
Thank you very much, Forav.
Foramen magnum decompression. Here is an 8-year-old female, 4-month history of suboccipital pain, coming with a cough headache, classical. You can clearly see here the tonsil is descending up to the C1 arch. There is a foramen magnum compression as well as the syringomegalia. And luckily, patient had no atlantoaxial dislocation. The indications are suboccipital pain with a post-tussive headache, paresthesia in the upper limbs, or when there is a presence of long syrinx, is that real indication for these patients. Here is the video which I am showing. You can see on the cranial and caudal end, patient is prone position and awake craniotomy done in position. And the first thing is you can mark the incision just more than 2 inches from the suboccipital region up to C2 spinous process. Exposing the muscle in the midline is the key in these patients, because ultimately to prevent the CSF leak, how beautifully you dissect the muscle and reapproximate will make decisions to say there is any fever, post-operative leak. You can see here on the cranial end that is a suboccipital region. I'm dissecting the muscle, and without coagulating, without creating any problem to the muscle, you had to dissect exactly the midline to have a vascular plane. So always you'll find one emissary vein at the suboccipital region coming mainly from the transverse sinus. You can restrict your dissection below that. And once you come to the C1 level, do not use the monopolar. Use the blunt dissection using the cob to push the soft area tissue. Ultimate exposure for us is to expose the complete foramen magnum and the C1 arch and up to the C2. So here I have kept a 5 rupees coin. You can clearly see here from the C1 arch, the dissection of the foramen magnum dissection or drilling should not cross beyond that. Or, if you cannot make out, use the 5 rupee coin, sometimes it will be bigger. Ultimate goal is the cerebellum should not fall down and only tonsil should be exposed whenever you do that. You can use another method is the 6 mm burr. Above the foramen magnum tip is the way you have to drill. Here you can see I have used the 5 mm burr, and drilling only 5 to 6 mm of the foramen magnum is the key. And anything more than that, if you do, you will end up the cerebellum descending into the foramen magnum, which will cause secondary stenosis of the foramen magnum, and the syrinx will not improve. So it is not only in the mid part of the foramen magnum to remove, you have to remove the lateral edges of it, where the foramen of Luschka will come in. That is a key point here. The drilling that part is very, very important. Then in this patient, because the tonsil is beyond C1, I have taken out the C1 arch. Otherwise, many a time, there is no need to remove it. So another important thing is taking the fibrous band which constrict the foramen magnum away from the dura. This removal of this fibrous band is one more essential point to prevent post-operative leak. Otherwise, your stitches will not become proper. So I have opened the dura in a Y-shaped fashion, the narrowest part at the C1, and the top part is just below the, just above the foramen magnum. Ultimate goal is to expose 2 tonsils and then to expose the upper brainstem, lower brainstem, and upper, the spinal cord. So if you see here, I am lifting the tonsil on the right side, and foramen of Magendie was not seen before that. Now I'm slowly lifting it in such a way that, you will get to, next thing will come is the exposure of the pica. So the caudal loop of the pica is visible already. Caudal loop is seen. You can see one vein which is also going up. So I'm lifting the tonsil. I always do. The tonsil are shrinking to a certain extent, the goal of which is to see the foramen of Magendie and foramen of Luschka on both sides, so that there is a smooth flow of egression of the CSF. And all the syrinx is purely happens in Chiari malformation purely because of the disturbing the dynamic of the CSF between the cranial cavity and the spinal cavity, where there is a higher pressure in the cranial cavity and the lower pressure with a negative suctioning because of the tonsillar herniation down, sucks the CSF through the foramen of Magendie and obex into the syrinx, into the cervical cord, creating a syrinx, rather than, going around the brainstem and the spinal cord. You can see here now I'm lifting the left tonsil. You have to do the meticulous work here. See, it is not just coagulation. You have to take out the lot of the arachnoid bands. You see here the arachnoid band I'm showing, where the arachnoid band has to be released. Then only the cerebellum will come up and the pica will go in. And then do not coagulate any pile vessels too much. Large pile vessels should not be coagulated. A small pile vessel, and in addition, the small amount of the cortex, the foliae of the cerebellum, should be coagulated multiple times to shrink it rather than shrinking the whole tonsil. very important point is do not shrink the whole tonsil. Then it will have a necrosis and patient will worsen post-operatively. You have to coagulate only the area of the tonsil which is covering foramen of Magendie and Lushka, and you have to repeatedly coagulate the same folium, then the tonsil shrinks further rather than wide area of the tonsillar coagulation. And every time lift it up from the foramen of Magendie and foramen of Lushka. See here, arachnoid you can clearly see which is holding the tonsil down. The arachnoid strands we call, or web, is the one which should be dissected away from the tonsil as well as the pica. And remember, do not coagulate the pica by any chance. Here the meticulous use of the microscope, meticulous use of the suction to take out the CSF, and keeping the bipolar at the lowest end, 8 or 10 amperes you have to keep, and do not keep coagulating the same area rather than the white tonsil, and slowly dissect the pica. See, at the end you can clearly see obex is exposed. The foramen of Magendie and the fourth ventricular floor, which was not visible in the beginning, is completely exposed, and pica on either side. And that is the end. Ultimately, you can see aggression of the CSF coming from the foramen of Lushka and Magendie. Easy flow of the CSF, which was not seen. Then I'm using a bikini clad. Now I'll show once again the, what ultimate goal is to make sure the flow of the CSF from a foramen of Magendie and Lushka should be easy, and it should egress on its own, especially at the end of the procedure. I will ask my anesthetist to give the Valsalva maneuver, and you have to see the egression of the CSF from the fourth ventricle down into foramen of Lushka and Magendie into the spinal canal. See there, the foramen of Lushka once again, you can clearly see the lower cranial nerves coming there, and you can see ultimate goal is this. You have to make sure the obex is seen, foramen of Lushka, foramen of Magendie, and sometime there will be a thin membrane covering the obex. The thin membrane covers the obex. This is arachnoid. I'll show you the thin membrane. See here, this is the thin membrane. Sometime I know if it is bigger and is not allowing it, if you remove that, the CSF which is already collected in the cervical spine will come out. So the goal is to see the obex, see the foramen of Magendie, Lushka on either side, lower cranial nerves which are seen here, at the end you have to see the lower cranial nerves, and both the pica arteries has to be exposed before you put the duroplasty. Clear visualization is mandatory in these patients. Then take the bikini shaped fascia lata. See, once again, the narrow part is at the cervical region and the wider part at the cranial region. So under microscope, stitch in such a way that, there no CSF flow, leak will happen. Very, very important to understand. Otherwise, we are ultimately, as I told you in the beginning, the dynamics between the cranial cavity and the spinal cavity has to be re-established to the original. In this patient, the original one, the dynamics is higher pressure in the cranial cavity, lower pressure at the spinal cavity. Negative suctioning happens because the cerebral tonsil coming in. If you do the CSF leak after the dural closure, the CSF start coming to the extradural space, and it will not, the dynamics once again will change, and the graft will go and gets adherent to the tonsil, and whatever the CSF dynamic pressure you wanted to change will become wrong in these patients. So ultimately, no CSF leak should happen after the dural closure. Duroplasty has to be watertight, which should be double confirmed with Valsalva maneuver. So then close the muscle layer, put a glue so that it will be easier. Put a large gel foam in the same shape so that the gravity will hold it, and see an arch, you put it back, and patient the whole thing you can close in a beautiful way so that the patient it will have a good closure. Once again, the layer has to be closed. Here is one clinical example. One more patient I'm showing you here. We have done a teenage person. 3 months later, there is a significant reduction in the CSF. You can see here the preoperatively, once again I'll show you, the preoperatively patient has a large syrinx extending the whole cord all up to the C2 level, and post-surgery 3 months shows significant reduction, and CSF flow from the cranial to spinal happens without any problem. So Thank you very much. And meticulous craniotomy, which will be just 6 mm below the foramen magnum, around this foramen magnum. C1 arch can be excised, coagulate, if required, and if meticulous neurosurgeon is available, make use of him to coagulate a limited amount of the tonsillar shrinking to expose the foramen of Magendie and Luschka. And watertight dural closure is the key principle with which you will take out the pressure head across the foramen magnum to reduce the syring formation in these patients in the KRA malformation. Thank you very much.
Thank you, sir. Do we have Satish, sir, online right now? Sir, can you unmute if you are online?
Can you hear me?
Yes, sir. We've just finished the recording of your talk, which was a beautiful talk on foramen magnum decompression and how you beautifully dissected and re-established the CSF flow. Any questions from the audience or the faculty? We have a question from Dr. Rakesh Lohana.
Good evening, sir. Excellent talk. So for KRA malformation, we move from just removing the band to keeping arachnoid intact to tonsillar shrinking or to see CSF flow at the end at the obax. What is your take? Well, have you changed your approach recently, or it has always been like this, or what is your take?
This thing is always like this. Any patient where the CSF is, the tonsil is herniated below the foramen magnum and up to C1, I'll make sure I will always see the foramen of Magendie and Luschka. And I think as of now, I have about 62 patients who are done this way. I always get the fantastic results in these patients. With respect to previously, in the beginning of my practice, I just had to do the bone removal without the dural opening also. But most of those patients will not have a significant relief of the syrinx. Ultimate goal of this is syring formation has to be reduced. And that slush and slough theory, which we mentioned, that whenever they cough, sneeze, the water within the syrinx will jump up and down and dissect through the cord, which will always happen once you make the pressure head difference between the cranial and spinal almost equal. Otherwise, irrespective of what you do, it will not reduce.
Thank you.
And this is the way always I do nowadays.
Yeah, thank you so much. Thank you. Appreciate it.
Thank you so much, sir, for your beautiful talk and taking time out for this. Next we have is Dr. Mohan Rao, who will be sharing his experience on transnasal endoscopic odontoidectomy.
Good morning, respected chairpersons, faculty and colleagues. I am Dr. Mohan Rao Patimandla, founder of Dr. Ross Hospital, Guntur, International Institute of Neurosciences, Guntur. Today I will be presenting a case of endoscopic endonasal odontoidectomy performed for persistent ventral cervicomedullary compression following a previously failed posterior fusion procedure. This case highlights an important principle in craniovertebral junction surgery. While posterior reduction and fixation remains the primary treatment, sometimes basilar invagination and atlantoaxial instability needs direct anterior decompression, which remains necessary. I will discuss our rationale for selecting a transnasal approach, technical nuances and the procedure and the clinical outcome. So over the past decade, endoscopic skull-base approaches surgery has significantly expanded surgical armamentarium, and compared with the traditional transoral approach, the endoscopic transnasal route offers several advantages. It is minimally invasive, avoids oral contamination, and minimizes tongue and soft tissue palate retraction, reduces postoperative discomfort. And it also provides superior illumination, panoramic visualization, and it gives the advantages. It translates into shorter hospitalization, reduced morbidity, improved patient comfort, and excellent visualization of the ventral cervicomedullary junction. Several surgical options exist for the ventral craniovertebral junction pathology. Historically, the oral approach has been considered a standard anterior route. While effective, it is associated with dysphagia, prolonged intubation, velopharyngeal insufficiency, and oral contamination. So posterior distraction and fixation techniques have revolutionized the AAD and can be treated successfully without anterior decompression. However, in cases with the anterior fixed deformity, extensive panels formation, and previous veil fusion, there is a persistent ventral compression. In these cases, especially the endoscopic transnasal approach offers safe, elegant, minimally invasive alternative, providing direct access to the odontoid while avoiding many risks associated with the transnasal approach. Selecting the optimal corridor to the craniovertebral junction is critical for safe and effective decompression. As shown here, the endonasal approach provides the superior trajectory to the odontoid and ventral brainstem, avoiding the oral cavity and minimizing the approach-related morbidity. The transoral route offers more inferior line of the sight and has historically been standard anterior approach for odontoidectomy. The trans-cervical approach provides access from below, but is often limited by mandible, tongue base, and superior surgical reach. Therefore, lesion location and patient anatomy and the position of the odontoid relative to the nasopalatal line are key factors in determining the approach. So, here the pre-operative MRI demonstrated persistent basilar invagination with the superior migration of the odontoid process. So MRI revealed significant ventral compression of the cervicomedullary junction associated neural distortion. And the posterior instrumentation was already done, and therefore the remaining pathology was the ventral compression. So here the posterior compression is showing the clear fusion. So the ventral decompression should be dealt in this case. So the MRI revealed significant ventral compression of the cervicomedullary junction, which is associated with neural distortion. And posterior instrumentation was already present and stable. Therefore, the remaining pathology was purely ventral compression. The objective of surgery was complete decompression of the cervicomedullary junction while preserving the surrounding neurovascular structures. So the patient is positioned supine with the head secured in a Mayfield clamp and the head is positioned in the slight flexion. Neuromonitoring is utilized throughout the procedure, including the somatosensory and motor evoked potentials. And the neuronavigation is registered to facilitate the precise localization of the CVJ and the anatomy. And after induction of the general anesthesia, a binostril endoscopic approach was established. Here we will see the this is the binostril technique we need to do. So for that we need to do the posterior septostomy so that two surgeons and four-hand technique we can utilize. The posterior equina and nasopharynx will be identified, and here the maxillary crest was drilling, and we are seeing almost into the posterior. Posteriorly, we are seeing the longus capitis and coli and the sphenoid sinus and the clivus and the anterior arch of the C1. Whatever the mucus was present, we need to remove that. Once the mucosa is elevated and preserved, whenever it's possible for reconstruction. So then we'll bring the high-speed drill, and progressive drilling continues until the axial thickness of the bone remains. Once the axial thickness, axial thinning was done, then we use the ronges to remove the upcuts. We remove the, using curettes, we remove the, and kerosene punches, we remove the bone. And the planus, whatever is during this process was there, that was removed. And then we delineate the tip of the odontoid, and we will remove that from central to the peripheral fashion. And frequent navigation checks were done, confirm the trajectory and extent of the resection. Particular attention was paid to the vertebral arteries laterally and dura posteriorly while we are drilling. As the drilling proceeds, progressively hollow out and detach the surrounding ligamentous attachments. And here we are seeing the posterior fossa dura, and we gradually remove that. And the pannus and compressive tissues are carefully immobilized away from the ventral dura. And here we can appreciate gradual restoration of the ventrocerebral space. Once we remove the total decompression, and superiorly towards the clivus and inferiorly beyond the odontoid process. Here the ventral dura is clearly visible, and whatever the ooze we are seeing is the venous ooze, and we will see the satisfactory pulsation. Navigation confirms the complete removal of the compressive odontoid complex, and then meticulous meticulous hemostasis was achieved. The surgical cavity was inspected, and then reconstruction is then performed with the duragen. This is a duragen plus, which attaches to that of the dura, and the procedure is completed without a neurological change in the intraoperative monitoring. Post-operative imaging showed, this is the intraoperative imaging, which showed the total complete removal of the odontoid. And then the post-operative imaging is showing, this is the pre-operative peg-like odontoid, and this is the post-operative, intraoperatively, the total removal. And this is the pre-operative odontoid compressing the neural structures, and here the removed, and this is the neural structures are removed. This is the post-operatively. The patient is walking. Pre-operatively he has 3 to 4 by 5, and post-operatively he was able to walk. So this is, in our experience, endoscopic transnasal odontoidectomy has been particularly valuable in patients with persistent ventral compression, following either due to the basilar invagination or due to the pannus, which showed demonstrated meaningful neurological improvement in motor function and resolution of the myelopathic symptoms. Importantly, we observed no major neurovascular complications, no CSF-related morbidity, and no procedure-related mortality. These findings are consistent with the growing body of the literature supporting endoscopic.
Thank you, sir. Any questions for Dr. Mohan Rao, sir? Thank you so much, sir, for your talk on the endoscopic assisted transnasal procedure. We'll move forward to the next interesting one, which is a case-based panel discussion. But
excellent.
that,
thank you, Mona, to be here. Thank you for the presentation.
Thank you.
Thank you.
Thank you very much.
We thank all the speakers of the previous session, Kshitij sir, Sai Dilip sir, Satish Rudrappa sir, and Mohan Rao sir. Next is a case-based panel discussion. May I have the panelists on the front row, please? Dr. Deepak Patel sir, Dr. Bharat Dave sir, Dr. Abhidha Shah sir, Dr. Hitesh Modi sir, and Dr. Parimal Tripathi sir. And the discussion will be taken forward by Dr. Jayesh Sardhara sir. Over to you, sir.
So good evening to all. First of all, thank you Rakesh Bhai and this association for this wonderful opportunity. And today we'll have a very, very interesting discussion. Those who are in the beginning of this journey of CV Junction, this will be very, very interesting because we'll highlight all the cases and we'll start from A to and we'll take it to the Z. All the cases will try to include it, which you will find in day-to-day practice. The next is not coming. Say over. Okay. So, where is the panelist? Yeah. Fall from the height, 5 feet. Early spasticity 4 by 5, little bit weakness. We can see the C1, C2. So first, let's start with the diagnosis. Abhidha, ma'am.
This is a mobile atlantoaxial instability with os odontoidium.
Okay. So right. So os odontium, relatively reducible joint. So how will you do strategy? Means what is the management strategy? Position? Will you?
So obviously he needs atlantoaxial fixation.
Of course.
Obviously there is no question about it.
Any
So
change in the position in this kind of case?
no change in the position. It will be prone position with Gardner-Wells traction.
Okay.
The traction will be given intraoperatively. The position you have to be careful when turning the patient. So basically what we do is I hold the neck, head end of the patient and my assistant is holding the neck, stabilizing it when we turn it. Then the neck is put in a floating position after applying traction so that you protect the eyes without, the eyes touching the horseshoe. The horseshoe is just as a secondary protection. And once you give the position, then you do a routine technique of Goel C1, C2 fixation.
So how much traction you give?
Depending on the weight, 1/5 of the body weight.
Okay. So I'm assuming that you give extension. So this kind of reducible AD will reduce in the extension, right?
Yes.
What if it is not reduced and if it is a non-reducible osodont?
So if it is non-reducible, the position does not change. My neck position does not change. I will manually manipulate the joint inside when I open and reach the C1, C2 joint. The distraction and the manipulation will happen in the joint, and by that I will reduce the atlantoaxial dislocation.
Fine. Then between the joint, if suppose it is reduced, you confirm with the CM. Will you put the bone spacer inside the joint or just a bone material over the joints?
Bone graft harvested from the iliac crest.
Iliac crest. Dr. Patel, will you take bone graft from the iliac crest or from the C2, C3 spinous process or what?
We take bone graft from the posterior superior iliac crest.
Okay.
In prone position.
Right. And C1, C2 lateral muscle, let's go there.
So just question, MRI done or not?
Yeah?
MRI.
In this patient? Yeah, of course. So,
I think need to see the level of compression or any other cord signal changes before we plan.
Okay.
And specifically,
Anything
I think
specific you want to
Madam
check?
mentioned
Yeah.
that I will try to reduce with little bit of extension by my hand when we turn the patient in prone position.
Okay.
You have to see whether it is reducible or not. And before fixation, it should be slightly in extension or at least in the neutral position rather than in flexion.
Okay. So nice, point is taken. Dr. Dubey?
Regarding the bone graft, 13-year boy.
Yeah.
So posterior crest should be, should not be touched. Maybe you can use the rib graft.
Okay. So, yeah, look at that. So just to take it forward, Dr. Dubey, you use C1, C2 or the Goel plates, Goel screw, the one transarticular screw or the lateral margin fixation?
No, C1, C2.
C1, C2. Usually in the C1 partial threaded, because if you want to preserve the ganglion, then you use partial threaded or complete threaded. What is the length of screw?
No, we usually use the full length screw, and then we usually use IONM navigation.
Because so there's
basically navigation.
Some surgeon use
partially
22 or 24 screws. And now particularly I use 26, 28, so it will make my life easy. The road will be fit easy.
Right.
It doesn't require a separate C1 or C2.
Yeah, you can rotate as
Absolutely. So ganglion preserve or not?
Yeah, usually one should preserve.
Usually you should preserve the ganglion. Okay. So I think this kind of, the all who are listening, the C1, C2 reducible AD, quite simple management. Use the position for reduction, C1, C2 fixation, and I think there's not a different kind of challenge. Now, so that's
Excuse
what we
me?
have say.
How old is it?
13.
No, not patient. How old is injury incidence is?
No, it was also don't tell you.
Nene, how long is the time between the incidence and patient taken for the surgery?
Okay, so you're asking me that
Yeah,
what? Yeah.
yeah.
So it was very old, I think, 10 years. So I'm not sure about that. Maybe it takes half an hour or 45 minutes. So what was
Would anybody try to check how much is it reducible before putting the patient in prone position?
Absolutely. So that's very important question. If you put a position in extension in reducible AD, always you should do the lateral CM, because if it is a osteodentum, there is a possibility sometimes your odontoid cross the ligament and it may goes anteriorly, and sometimes it's locked there. So very nice point you have taken. It has to be checked before you start the fixation. Is it the same point you want to? Yeah, absolutely.
One more question.
Yeah, please.
If you think that it would be very difficult to reduce it from the back only, would anybody try to release it from the front?
Okay.
In first stage?
Dr. Sudhir, please.
This will get reduced when the imaging wise it looks like it will get reduced, but you can always do these days the first thing is you do posterior. If it does not get reduced, you go anteriorly. That will be in 10 to 15% of the cases.
Okay. So let's move to the next question. This is a 12-year boy. Spastic quadriparesis, bilateral tingling sensation. Of course, we can see the compressive myelopathy here. If we see the flexion extension, little bit reduction. So we can see here that if you change the position, you put it in extension, you open the capsule, it will reduce it, right? Now, we see the compressive myelopathy here. Will it be the same strategy or different strategy for fixation? Dr. Abhidha, same or different? Same. So it's again the reducible AD. Sometimes what I feel, this kind of patient with compressive myelopathy is high, there is a retroodontoid. It's a chronic, because traumatic fracture is acute, but this kind of patient is chronic history. Difficult to reduce. So this, what I will push this slide, because this kind of patient, it's very, sometimes you open the capsule very widely, sometimes you distract the C2, C3 joint so that it's reduced further, and it's very important to put a CM and confirm before you fixation. Just to highlight that. The same we have done. Okay. Now what about this? Dr. Dubey, 11-year boy, progressive spastic quadriparesis, 4 month. Of course, there is 4/5 power, spasticity. Now something different. Any highlight on radiology?
Yeah, I think again this needs foramen magnum decompression too. And
foramen magnum decompression.
Usually we distract and extend both.
Okay.
After putting the screws.
Okay, so you mean to say this is the AAD with basilar invagination because it is crossing the odontoid process. Perfect. But there is no ACM, no carry malformation.
Yeah.
Still you would like to go for magnum decompression.
Yeah.
So that foramen magnum become then how you reduce it? Because this is kind of chronic and basilar invagination.
So
Distraction.
we distract and then extend.
Extension. You put a spacer?
Put a spacer, yes.
With navigation, without navigation?
No, we always do it with navigation.
With navigation?
Not a single case we do without navigation, without the whole O-arm navigation and the...
Perfectly all right. Yeah. So the answer is spacer with distraction with navigation.
Yeah.
Dr. Dubey, anything different you want to do or say?
If you have a O-arm, you will always check how much reduction has taken.
You have O-arm, so you use in the O-arm?
Yeah. This will all be done in O-arm because after you have done the distraction, you will see how much space is there posteriorly. You can tailor whatever you plan to do. But if you have to do anterior later on, it will be in a next setting, not in the same setting it will be. But
Okay.
you will do a foramen magnum decompression if you don't get an adequate size on the spinal canal size is less at that foramen magnum level.
So Dr. Patel, there is a basilar invagination. So intraoperative traction or preoperative traction, would you like to give preoperative traction before surgery or just intraoperative traction for stabilization, or you want to manipulate?
No, intraoperative traction only, no preoperative traction.
How much you give?
Intraoperatively under GA, it reduces. And I would like to use about 3 kg of weight.
3 kg,
Yeah.
almost.
Yeah.
Yeah. So
I think it's similar when you put the patient under GA. I think soft tissue will relax and you will able to get better reduction along with your positioning. Additionally, if there is more basilar invagination left, C1, C2 spacer would definitely make a difference.
Would you like to go for CT angiography in this case before surgery?
Definitely. In any case, CV junction surgery, you have to go for CT angio in all cases.
Dr. Sudhir, you are good for all. So here just my take is different here. If you have suppose there is an economical issue, suppose if I tell you that there is an option that patient may not be affordable or it's not possible or something, any special indication where you would like to go for CT angio? कि इसमें तो करना ही पड़ेगा. Dr. Abhidha?
So this is an assimilated atlas.
Yeah, absolutely.
So there is a chance of a vertebral artery anomaly. So
Absolutely.
when you have such a situation, CT angio is preferable. But of course, there are times when we have to operate without a CT angio. But at that time, you should be aware of where the vertebral artery anomalies will come, especially in a case with atlas assimilation.
Yeah.
So on the pedicle of C2, so even if you don't have, you have to be careful when you're dissecting the ganglion.
Very nice. So we have our own study at SCPJ of more than, yeah, sir.
Let us not give message that we operate without CT angio. It is must.
Must.
I think this is must. This is a golden rule. You know, if the patient is not affording, maybe you send it to somebody, or rather, send it to the institute.
Why I highlight this point? Because there are traumatic ADs, there are something so different AD. If the message is, if patient having a occipitalized atlas on the MRI, don't go in the operation theater without CT angio, because in peripheral private practice, sometimes somebody may try, oh, there is no CT angio, should we go or not? The message is for that.
Yeah.
I absolutely agree. If ideally it should be gold standard.
Yeah.
But this is the...
If patient is not affording, better to talk with your radiology friend, get discount and get it done. I think it is a better option. It should be
the
done.
The point is in the occipitalized atlas as per study, more than 20% case, the vertebral artery will cross the C1, C2. So the point was that it is very important. So the same we have done posterior C1, C2 dissection and fixation.
Excuse me, one more point.
Yeah.
I would like to use even Doppler intraop if we don't do CT angio.
That is
And in
Very
cases
nice point.
obviously pulsations are failed, we get, then avoid that area and do occiput to C to 3 feet fixation.
Yeah, that's an absolutely nice suggestion. Okay, so, yeah. So we see here, there is a 11-year girl, gradually spastic quadriplegia, also the bladder ball involvement. We can see here there is high basilar invagination is also retroverted, severe compression, although the occipitalized is partial. So, Dr. Dubey, how you manage this?
Same, probably the way we discussed earlier.
Okay.
Yeah.
So
but
because
I would make a point here, just to share with you. In a parallel practice of ours, we always put the traction on for a day or two in order to.
Before surgery, you are saying?
No, before surgery.
Okay.
In order to have the impression that this is a surgery where the risk is very, very high. So patient understand that as well, and we have the counseling because there will be several visitors coming every day. So we usually do that in our practice scenario.
Fair enough. Anything change or this? Okay. Okay. Suppose during surgery, we are not able to reduce this joint, and the CM shows that it is not reduced. There may be many reasons. Maybe lack of experience, maybe something else. What do you do? Will you fix it like that way? Sometimes it's possible, like asymmetrical joints, very difficult to reduce. You don't want to put a pressure. It's happened. what is the next step? Anybody? Dr. Patel. It is not reduced during surgery. Or you want to say that everything will be reduced?
Most of the time it reduces.
Okay. Dubey sahab.
In some case, if I'm not able to reduce, I will do a foramen magnum decompression, put the screws in C2, do a expansile duroplasty also, and then later on go for an anterior approach.
Exactly. So sometimes it's happen, yeah.
But the anterior could be very difficult to do. So, yeah, have you done the nasal one? You do the nasal one. Yeah, because then will be easier to do the nasal one.
Absolutely. So sometimes what I've seen, more than 160° when there is a basilar invagination, like the spondylolisthesis, it is not only the sagittal, it will be also the rotational component, it will be the cornal tilt. In that case, very difficult to reduce because there is no space for going ahead. Sometimes it's okay to do in only decompression in situ fusion also, right? Because this is the progressive anomaly. If you just stop it, at least it will not progress further, and with the time it is improved. So this patient, we have tried to reduce it, not distracted well, and then we had to go for transoral decompression. Now this is, you see the 10-year boys, again the same things. Look at the vertebral arteries. Now there is a single vertebral artery. The opposite side is also only aplasia. So, Dr. Abhidha, single vertebral artery, CV junction anomaly.
So the vertebral artery is on the left side. It is a single vertebral artery. Right side joint seems okay. Both the pedicles are okay. So first I will fix the right side. If successfully done, that is good. I will still try to fix the left side because the vertebral is near the lateral mass of the atlas. So on putting the osteotome in the joint, the artery will be pushed up. So within the joint, I will put the C1 screw. I will try, but if there is too much manipulation and if there is a possibility of injury, I will accept one side fixation.
I'll accept the one side.
Same. Any other alternative? Suppose it's very. I am doing this a second case. Maybe suppose I don't know how to mobilize the vertebral artery. Any other alternative you would like to discuss here? Dr. Dubey, alternative.
Do an anterior approach paraphernalia.
Anterior, you can try with the anterior. What about translaminar screw in this? Occiput, both translaminar screw, and we fix it. We bypass the C2.
That also can.
Will it work?
Not
because
for the
we
joint
see
distraction, but it will work.
So it's just so there are two alternatives we would like to add here. Suppose it's a single vertebral artery. Very nice point by Dr. Abhidha that always fix the opposite side first, because in the single vertebral artery during surgery, if you damage this, then there is no space of stabilize. At least you have stabilized on the other side. The second point, if the C2 lamina is good enough, then you try the translaminar. Third, because we can see here this is occipitalized atlas. So it's okay to do occipito C2, C3 fusion. Do you agree with me?
Yeah, I think agree.
Yeah.
So we have been doing the translaminar in many cases, but then it has to be with the navigation. I'm sure you have the navigation as well. Or do you do it without navigation?
Again, this is a nice case.
Because it's a,
Yes,
Dr. Rakesh, you want to add?
This is a nice case why CT angio is required.
Absolutely,
right?
Absolutely. So that's what we say. Occipitalized, it has to be there. Anomalies has to be there.
Yeah, so
Doesn't
C2
seem high riding on the left side. Does not look like high riding.
Yeah.
There is a good amount of pedicle. And if the artery is on the lateral mass, I can try transarticular.
Transarticular screw also. Yeah, absolutely correct. And what we have experienced in few years, the vertebral artery mobilization is not a hard procedure because it is full of around the venous plexus, large diameter. It's more, better to mobilize rather than to take a chance of the screw and injured it. Okay. So we have mobilized this vertebral artery and we have done the fixation same way.
What about the inferior facet screw on the left side? This side, on this side. Instead of translaminar screw, you can put the C2 inferior facet screw.
Yeah, very nice point. Very nice point. So what he want to say, you want
because
to bypass
vertebral
the
is quite away. Vertebral is quite away. You can safely put the C2 inferior facet screw.
Yeah, absolutely. You want to say here, right?
Instead of translaminar screw.
C2?
Instead of C2 inferior facet screw on the left side.
Yeah.
On the side of dominant vertebral.
Point is taken. Point is taken. Well taken. Nice. Now this is the case which is something different. Here we have a AAD Here we have carry malformation and foramen magnum compression. So here the thing is just we want to add the FMD, right? Now here again the same things. Of course we are going to do the C1C2 distraction and fixation. But what about here the debate is bony versus dural opening for the foramen magnum decompression, because there's a lot of study says if your carry malformation is because of basilar invagination, it means reduction in the posterior fossa. So bony decompression is good enough, no need to open the dura. What is your take, Dr. Dubey?
I have burned my hands when if it was a very tight compression, and what happened after the post-op period, after 2 weeks, he started developing syrinx, which was not there before. So after that, if I have a tight thing and I think the adequate decompression is not done, I will do expansile duroplasty. After
Same.
burning my hand, I have done that.
Same, Dr. Dubey? Here,
No,
any change in the panelist?
No, we don't do it. We
Okay.
don't do it.
So duroplasty, right?
We do not do
foramen
duroplasty.
magnum decompression. I will not do foramen magnum decompression.
You will not do, you will do only C1C2 fixation. Why?
There is no need. There is a gross atlantoaction instability. Look at the joints. The
Okay.
joints are completely malformed. I will be able to distract, reduce, and realign the whole system.
Absolutely.
The Chiari and syrinx will slowly disappear.
Disappear. Very nice.
The
So,
decompression you only do when there is no, you cannot reduce it. Means if it's only that case.
of course, of course.
I think in this particular case, we can take chance of not opening the dura.
Okay, so here there are so many studies. We have also followed the study in 300 patient in what we have done in such case with the tight posterior fossa, we have opened the only bony decompression with 270-degree foramen magnum decompression, release the band, we leave it. The result was same if we open or not open the dura. So that was just I wanted to highlight. Now, one more point Dr. Abhidha has said, if the joint is symmetrical, you see in the pre-op and there is also indicator that you are going to completely reduce, so maybe we doesn't require foramen decompression as per his experience. So the same we have done, FMD and decompression. Okay, this is the case, 43-year male, we see here, there is no atlantoaxial dislocation. There is no basilar invagination, pure carry malformation. So again, look at the large syrinx. Now there are two scenarios here. Look, forget this patient. If it has to be, if the case is asymptomatic carry, Dr. Dave, asymptomatic carry, the same patient, how will you decide when you do go for surgery or you observe or when to do what?
No, I think supervised neglect. We observe.
You observe if despite of
if there is no, it is asymptomatic. You ask about asymptomatic.
asymptomatic,
Asymptomatic.
you observe.
You observe.
What about this syrinx? I have seen many patients in which syrinx is large, but the patient is asymptomatic. Still you observe.
Still we observe.
Same for all, right? Any difference?
I'm not sure if this patient will not have any symptoms. First thing,
But
there will
sometimes-
be some subtle symptoms. There will be some signs in presence of such a syrinx. Chiari, if it is only Chiari, maybe the patient is asymptomatic. Still, many of them have neck pain. So if it is only Chiari without any symptoms, still consider observation. But with a syrinx, first thing is that there will be symptoms or signs, and then think about it.
So I am sure that you would do only C1C2 distraction
Of
here.
course.
You also, Dr. Patel?
I would also like to do contrast MRI. Sometimes rarely
Okay.
intermediary
Nice
lesions
point.
can
Nice
be
point.
there.
There is no tumor, of course. So it's a syrinx. But C1C2 fixation and distraction or only
We
decompression?
simply do foramen magnum decompression and also suboccipital craniectomy below inferior nuchal line and till lower border of the tonsil is reached. Sometimes we might have to remove the C2 and do expansile duroplasty with local pericranial graft.
Okay, very nice. Anything different? No. So look at this one. Now this case, there is a carry malformation, of course, but look at this platybasia. It's a type 1 BI. Dr. Abhidha, any change? Because this case is also suggestive of progressive instability. Now that case, it was not sign, it's not reflection of any C1C2 instability, but this case, it's gradually progressive. We can assume that after 10 years or it may be the BI may be progressed. Now what do you do with this?
So this case, you have not shown the lateral joints. The joints will be pretty high. So getting into the joints is going to be difficult. But yes, you have to try to get into the joints and do C1, C2 fixation because you have to address the instability. There is basilar invagination and you'll have to treat it. Otherwise, you will come back with,
decompression.
Our philosophy has changed over the years. We are doing only C1, C2 fixation. And to see the instability now, we recommend dynamic rotatory CT imaging. In rotation, right, left, and lateral right and left tilt, you will see the instability.
Dr. Dubey, you following the same strategy for type 1 BI with ACM?
You have to do C1, C2.
Decompression. Sir.
Madam, can you tell about the rotatory instability? Can you please?
Sir, Dr. Dubey, just one minute.
Sorry, she was saying something different, so that's why.
No, I'm just, he was finishing.
No, you have to do C1, C2 if you are thinking it's going to progress, that you should address at the same time, rather than wait for it to happen.
So you would like to say decompression with C1, C2 fusion? Okay, madam.
So for a long time, we've started doing C1, C2 fixation for Chiari. We used to see the intraoperative instability. We were not able to convince or demonstrate it. So recently, over the last 3-4 years, we've started doing rotatory dynamic imaging. So one is right rotation, left rotation, right lateral tilt, left lateral tilt. Lateral tilt, if your distance is more than 5 mm, then it's indicator of instability. And for rotation, there are some 4 types we have described. But generally, what you see is at least about 75% of that facet space will be open. You will actually see the difference between the atlas and axis. Sometimes it's even 90%, and that's where you can get to see the instability.
Fine.
Thanks.
So same we followed. If I find instability, any kind of instability per name, if there is a with Chiari, I do only C1, C2 fixation and distraction. We have published the study also in the debate. Now, 12 years boy, spastic quadriparesis, MRI, so also you see the C1 arch is compressing posteriorly, odontosis is compressing from anteriorly, and there is atlantoaxial dislocation. Look at the joint. Any comment on this joint? Dr. Dubey?
Yeah, I think it is subluxed or maybe dislocated on one side.
Okay, so patient is having torticollis. Common in torticollis, we find this kind of joint. It's an asymmetrical facet joint. One is vertical, one is oblique, and we can see here. So, Dr. Dubey, any planning strategy before you take this patient into OT? Sir, mic please.
Show us the X-rays, dynamic X-rays, dynamic CT, and the MRI.
Okay, so sorry, I have this only. But there is, I can say, there is no basilar invagination. There is a asymmetrical facet joint, and there is no vertebral artery anomaly in this case. MRI showing a significant cord compression with T2 hyperintensity changes.
After the first year is over, the macula itself forms in a different place in the retina. So, in order to regulate its vision, the child will continue to keep in a torticollis position. That is one thing. And second is there are secondary changes in the face, cranioscoliosis, fascioscoliosis, things like that. So however much we correct, it is doubtful whether all the pains that we take at this level will help the individual to any extent.
Thank you, sir, to bring this notice. Dr. Modi, yeah, any, how you plan this case?
I think occiput to C2, C3 fixation. I am not sure that whether I will be able to open up that space and correct it, that vertical facet joint at C1, C2. But I will go on the opposite side, try to distract it, and then observe on the opposite side. Yes, again, as Dr. Bharat Dave has mentioned, that OAM navigation is, I think, we also use the same thing in almost all of our cases, and then we take a spin again and then see whether it is reducible or not. I'm not sure, but I would like to avoid that joint
Okay.
to
Yeah,
manipulate.
I think we will OC to C3.
OC to C3. Would you like to put a spacer on one side when there is asymmetrical facet? Maybe it helps to correction of torticollis.
So differential distraction is a strategy where you put spacer on one side and don't
Yeah.
put on the spacer on the other side. We used to do spacers some time back, but bone graft suffices, so we are not using spacers in the joint anymore. Very, very rarely.
But there is
in
one
this
side. One side is a nice horizontal joint. What if you put a spacer on that side and you put a bone chips on this side? Maybe it reduces.
So left side you're saying put the spacer. So
No, I'm just asking.
Yeah,
Is it the way?
we don't do it, but you could try it. I will be able to reduce this. First fix the right side.
Okay.
So I will get that kind of alignment already by fixing the right side, and then I'll go on the left and fix it. Maybe put more bone graft on the left side.
So I, at that time probably, so I tried distraction, put a spacer on both the side, one side it was not, and then we put a spacer, you can see on the vertical side also, and then horizontal side also. But what happened, because the joint was asymmetrical, the odontode goes more in the canal, the patient's power would deteriorate. So that was the message, the same mistake I have done. So there was asymmetrical facet. If you put a spacer on the vertical side, the odontode goes in the canal and patient deteriorated, and patient went up in the ventilator, and the next week I had to do this ventral decompression and then patient improved. Yeah.
Under general anesthesia and neuro monitoring pre-operatively before you position the patient, and be prepared for the anterior release on the left side first.
So what happened now? The bony joints which is deformed, bony joint which is congenitally deformed, any release will not able to change the space. It has to be a mechanical. You release the joint when there is a symmetricity. If there is a cross symmetry, even you release the joint, it will be a torticollis. That's the problem in this kind of case.
So basically, whenever there is a vertical facet joint, I think it should be better to avoid from that side. Try to achieve reduction whatever you get wherever the joint is horizontal and your spacer is going to sit on that joint. If it is vertical, then it is not going to sit.
Exactly. So as Dr. Dubey said, with the monitoring, if you have a monitor, you have a vertical joint more than 160 degree, and then you are trying to distract, because there is a limit. If you distract more than 5 millimeter, you cannot see that cord is stretching. Patient will end up with immediately the plagia, except neuromonitoring says something. So I think that's a good idea. Sometimes in situ fusion with only decompression is also good enough. 15-year male, severe neck pain, spastic quadriparesis, respiratory compromise. Dr. Dubey, we can see the contrast enhancement in severe neck pain.
This is enhancing tissue. This is contrast MRI?
Yeah, this one.
So age of the patient is 15 years old male.
Yeah.
Any other history of something?
Not a past history of any specific.
And
came in the emergency. Severe neck pain. Patient is crying.
So the bones are eaten up on this thing. All scans are not there. So
Yeah, but we can see the restriction, whatever I have.
Yeah.
The coronal and sagittal and C1 and everything is gone.
So it may be infective. There's history of tuberculosis or something.
Yeah.
So
it's a CVJ tuberculosis, absolutely correct. Now, how will you strategize?
So it
this?
is a reducible thing, so you have to just fix it properly, that's all.
What about this ventral compression? Because of, you see the anterior soft tissue, anterior infective material which is compressing the joint, patient is having respiratory compromise. So directly you would like to put in the OT.
So sometimes no, in posterior if it's all pus and it's granulation tissue, you go from the sides, you can go a lateral trajectory with a port and you can take that thing out. It doesn't require a ventral.
Okay, so you are saying we'll put a prone position, we'll go from back to anterior, we'll reduce the 360 degree cord and we'll fix it. Yeah, Patel sir.
I would like to go by anterior approach and decide the histopathology of the material which I obtained from transoral route. If it is tuberculosis, then...
So you go for transferal route first?
Yeah, first, and then posterior fixation later on.
The same setting?
Same setting.
So
Maybe
transferal followed by posterior fusion?
Yeah.
So nice Abhay. So if we are able to do from posterior, you do posterior to anterior or transferal posterior fusion. So the crux is 360-degree decompression of the cord is important because patient is having respiratory compromise. Now question is, if you see the joints, the C2 is distracted, the C1 is distracted, where will you put a screw?
So you have
Yeah,
to tell
No, I think we go transpedicular, the screw, pedicle screw C3.
See, in tuberculosis bone, it will be very difficult. So
Difficult.
you go
It
down
will
as
not
much.
the hold. It will not hold.
It won't hold. It won't hold.
Okay.
Yeah.
Okay. You can go from OC put C3, C4. It's a longer one. Yeah. The same suggestion.
Yeah, I think I would do the same thing.
Okay.
That's what I
So
said.
what?
Pedicle screw. Do you put the pedicle screws?
Yeah, in this, that's why I was
What
saying
did you
the
do?
pedicle is completely destructive.
No. It's the C3, C4.
C3, so in this case, I have done translaminar because lamina was good. But I absolutely agree. If it is not working, see, this is the pure case of infective C1, C2 instability. If we are not fixing the C2, which is must, then the post-operative patient, you may not ambulate him, even with the collar. So we should try the C2 to take at least C2 because there is no occipitalize here. So we have to take a C2. Otherwise, C1, C2, C3, whatever we can take, we can achieve. Fine. So Dr. Rakesh, we have 10 minutes, right?
Jayesh?
Yeah.
So generally in TB, what we see is
Yeah.
one side joints are okay. One side will 100% be destroyed, but on one side you are generally able to get a good C1, C2. And if not C2, you can do inferior facet in this. C2 inferior facet will be okay. For
Nice
this.
point.
So Dr. Abhidha, how do you put C2 inferior facet? What is the trajectory? Speaker, mic.
So you identify the where the junction of the lamina and the pars is, and you go to the C2-3 joint. So you are able to see the C2-3 joint, and then just direct it laterally, downwards and laterally. If the joint is big, C2 joint, it won't reach to C3. It will be a big, large joint which will just small screw. We use about 16 mm screw, and it will just fit in the C2 joint. But even if it takes C2-3, no problem.
Sometimes subfacetal screw, you can bypass the vertebral artery foramen, you can take inferior articular surface and you can directly put the screw in the body. We have done, it's called subfacetal screw. Sometimes it works, not in this case. This is the last case, I think.
Done. I think we are.
Yeah, we are done. Longer construction, OC put C3.
So don't worry about it. When the healing takes place, you can always remove it. It's not a
Okay.
big thing.
So last Dr. Rakesh. Finished? Okay. So our organizing person is saying finished.
Sorry. Yeah,
so
thank you so much.
all
Excellent
the
talk.
panel.
Yeah.
Thank you. I was just thinking all the time, where are these kids going? They are not coming to Ahmedabad, so they are coming to you probably.
No, sir.
Thank you.
The UP was the hub for that. So
Thank you so much, Jayesh, Sardhara sir, for a beautiful case discussion. Can I have Dr. Deepak Patel sir to please present the memento to Dr. Jayesh sir, please? Thank you so much, sir. For our next session, thank you so much, panelists of this case-based discussion as well. Next up, may I have Dr. Tharadra sir, Dr. Jigar Anandjiwala sir, Dr. Deven Jhaveri sir, Dr. Mukesh Patel sir, and Dr. J.P. Modi sir on the front row seats, please. Our next talk is from Dr. Subir Dubey sir, who will be talking about cervical disc replacement.
હતા કે અમને ફોન નથી આવતો એનો મતલબ ક્યાંક બીજી જતો હશે. જવા દે યાર બાપા, એનાથી તને કહું આખી હોસ્પિટલ ત્રાસી ગઈ, એ ફ્લોર આખો ત્રાસી ગયો હતો કે સાહેબ આને બહાર કાઢો. એમડી મેડિસિન થઈ ગઈ
to make a case for cervical disc replacement. In my practice also, I tend to use it in a lot of constant, and suddenly I discontinue doing it, and then again I do it. So there are some reasons for it. So cervical disc disease, we all deal with it, and if you look at the literature from the 80s onwards, a lot of surgeries have been done. Initially it was discectomy with or without fusion. In late 90s, early 2000s, there were very lot of articles which used to compare between plain discectomy and fusion, and people used to get equivalent results. But over a period of time, people noticed that not doing a fusion led to facetal pain in the long-term outcome of the patients. So fusion got accepted as a norm. Then in the 2000s, disc replacement also was in the late 90s, which it came. And then there were foraminotomies versus disc replacement, which happened in 2000s. And then in 2010, all cervical spine used to be treated like a deformity. So people have started planning as a deformity of cervicals, this thing. And post-pandemic, we do everything together and think in a 3D fashion. So the case for cervical disc replacement started because it was first introduced for combat people. And Indian Army had bought 100 plus cases. The US Army used prestige disc replacement, LP disc were used. And they claimed that they went back to their duties in 2 weeks' time. So I've attended certain presentations in which they said that the young, healthy males will go back to duty at 2 weeks' time. But surprisingly, that is not the case in our local practice. And what they have claimed at that time, it has not happened. So these are I did this, believe this, and did some things. So this is a patient in which you have a Klippel-Feil anomaly, and you can see a long segment fusion there. And you can see that this disc I replaced, and I found out that this is not going to hold. So I did a ACDF at the same time. Because this was going to fail anyway, means I was trying to give a motion for a Klippel-Feil so that whatever time they had, she can use 2 discs. But this is a disc which is going to fail, and then I did a ACDF at the same time. I was lucky. The other patient is a radiologist who used to do a lot of ultrasound. The disc went on well, but the patient had a lot of problems in the post-operative period. And if you look at the facet joint, you study the joint pathology, everything looked like perfect for this patient, but still she didn't do so well, and in the end we had to do a ACDF for her. So in my experience, I do anterior foraminotomies also and posterior foraminotomies also. For anterior foraminotomies, my criteria is I will do for a young person who has a mobile neck without any pathology and a foraminal disc. Posterior foraminotomy I do for older people who have osteophytes, a foraminal stenosis, and it is who have a especially nighttime pain without a significant disc. It's a foraminal pressure that I do. I have done more than 3,000 cervical spine procedures, and I've done 136 cervical disc replacement. And still, whenever I see a patient with a disc which is soft, I will still be scared whether I will offer him foraminotomy, disc replacement, or ACDF. So I now tend to follow more of what the profession of the person is. If it requires constant bending of the neck, then it is going to be a ACDF procedure compared to any other procedure. That is what I'm sure of. Foraminotomies I will prefer to do compared to a disc replacement in my practice these days. I have done 4 revisions of that. So going back to the disc, we all know that there is a flexion and extension movement which is there, and lateral bending movement at C5-6. And if you're trying to do a disc replacement, you should always look at the facet, because one of the most commonest thing which is preserved is lateral bending, or it may sometimes increase also. So if the person has a facetal pathology and you have such a movement which comes in, the degeneration is going to get accelerated at the facet joint, and that will lead to a lot of problems in the post-operative periods. We all also have to know that there is something called rotation, the axis, the center of rotation which is there. If you look at the upper cervical segments, it is on the lower part. That's why the osteophytes form at the lower lip. They don't form in the upper lip in the initial stages in the upper cervical spine. And if you go to the lower cervical spine, then they tend to form superiorly. So C6, 7 will be at the superior part. C5, 6, you will have more at superior than inferior, but they will be inferior, which will be there. And above that, they will be at the superior part, which will be more. So whenever you do a foraminotomy, this is very important, because where you go and take out the osteophyte and the disc becomes very important to know this fact, which is important. And there was a quality, means they did some studies and they found out what the discs can give. So whenever a disc artificial is made, it has a center of rotation axis which is at below, and that's why the flexion extension movement is quite good. So facets have to be very important whenever you do a disc replacement surgery. The lateral extent, even if the center of extension is there, you will find at the lateral side, the facet joint will come into being, and they will always limit the amount of lateral bending, which is normally also happens, but will also happen because the center of rotation is quite low in these patients. And there are discs which are of various types. There are 3-component disc in which you have 2 end plates and a center material which is there. And you also have 2-component prosthesis in which you can have different forms which may be there. There may be cup ball, there may be like a saddle which may be there. So with these forms, they are there. And each one does a lot of good flexion extension. There's this limitation of side movement which is there. And one component, this is an old Bryan disc which is on the top, which is the A disc. This disc was used initially, but it has not fallen. There was a lot of problem in doing this surgery because there was a lot of shilling involved. You had to give it the perfect angle and perfect shape to get it installed. So normally now people are using 2 or 3 component disc which are they using. And we also have to know this artificial disc will change according to the patient's musculature, according to the patient's what the kyphosis, lordosis, whatever the angle it is there. So in a kyphotic spine, if you do this, there will be increased demand on the musculature and more strain on the cervical spine will happen if you use it not in the neutral position, if it's not a neutral posture. There will be more wear and tear. There have been a lot of studies of this cervical disc arthroplasty where they have compared the cervical 1 level and 2 levels, and they have shown that cervical disc replacement does do radiological, it gives more benefit, but clinical outcomes are hardly not statistically significant, though they show a tendency to become better compared to the other thing. And in fact, there were some articles which said that when you do a 2-level disc replacement, the outcome of adjacent level changes becomes significantly less. And that is what happens. So 2 levels patients are on the long term, they do much, much better compared to a single level disc replacements. So additional level of surgeries become less. The adverse events are nearly the same, but the second surgery, if you do, then the adverse events also increase in this thing. So if you look at this, there are 2 points which basically make you between a ACDF and adjacent diseases. Between a disc replacement is that you shouldn't have a adjacent segment disease, which is clinically, if you put a lot of lordosis there and if you plan your ACDF well, then the chances of that happening in my practice, I have not seen it very frequently. And the long-term durability of both the procedures, once functional, is quite good. And that is a summary which says that. So if you ask me after all these studies which you have gone through and this thing, what I should do. So choosing a ADR patient should be a young patient with arm and neck pain who has failed conservative measures. He should have motion in bending zone. Facet should be pliant. There shouldn't be no instability, no metabolic bone disease, no kyphosis, no long segment clipal feel. And the strategies should be, you should put the patient in slight extension because that is what you try to achieve in the end. Otherwise, there may be a problem. You have to do a discectomy from one side to the other. Your osteophytes have to be removed, but you have to wash away all the bone which is possible. And you should always stick to the midline. Midline is the most important thing when you are doing this surgery. So your retractor system should turn towards the opposite side whenever you are putting the instruments and you are doing this. Sequential steps are there, and the most important thing is hemostasis to prevent ossifications to happen. These are just some videos. I will just go through them. But I will tell you the one single most important thing which is there is you will always have complications. Complication is, one is when you are doing a wide whenever you do a wide dissection, you will have more of venous bleeds from the sides, and that has to be controlled. And sometimes you can also have in the post-operative period, you can have a bleeding from one of the neck vessels. So this is one patient who is an oncologist with us. She was doing fine, and after 3 hours, she got a neck swelling. We rushed her to the theater, and this is when we opened it. This is a disc we have replaced for her. And this is my finger, which is just guarding that blood vessel. So I will just show you the bleeding. So sometimes these things also happen. So this was an artery from one of the sides. From the longus colli, it was a big bleed, and then it got settled. There was no problem after that. So a case for cervical disc replacement is people in the army have used it and said to gone back to duties in 2 weeks to 6 weeks time. But wrestlers in US and Japan will use foraminotomies compared to anything, disc replacement or this thing. Famous actors used ACDF, and some politicians who used it in revision when they just did an discectomy. Spinal surgeons, means I know 3 spinal surgeons who have undergone who had a disc problem. So can I ask you, if you have a cervical disc which is significant, you will undergo a ACDF or a foraminotomy? Foraminotomy, ACDF, or a disc replacement? Can I ask? Just raise your hand for disc replacement. Okay. For ACDF? And for foraminotomies? So I will tell you, this is I know 3 surgeons who are quite senior, international surgeons, not Indian surgeons, who have undergone ACDF, one at one level, and they have undergone ACDF again when they developed adjacent level disease. Because everyone felt that when you are doing this, your neck pain, amount of pain will increase very significantly if you do a ADR. And the problem with the disc replacement is this only, that patients have post-operatively neck pain, which you are not able to settle a lot of times. So that is one thing. A lot of rehabilitation is required for that.
Thank you, doctor.
Yeah.
Can I just, we have not listened about any status of uncinate process in decision making of disc replacement.
So uncinate process hypertrophy is a contraindication for doing this disc replacement.
Even without osteoarthritic, any anatomical variant by
Yeah,
birth or anything?
so if there is an abnormal anatomy, because that will limit your disc replacement, this thing. Any facetal abnormality, any uncinate process abnormality, you cannot do disc replacement there.
Sudhir, I raised my hand for total disc replacement. It's not that its result is superior, that's why. I raised the hand because I want to be with the technology, that's why. I don't think the results are different.
Yeah.
Say, Hilbrand's basic paper itself quotes these things very clearly. How much it will, the adjacent segment is too much emphasized. But if this is not done, the next future will not evolve. That's why I'll be supporting TDR for myself.
No, but one more thing is, I have seen one ultrasonologist and one anesthetist who used to do intensive care. I've done disc replacement for them, and I've seen them developing heterotopic ossifications after 1 or 2 years, and having a miserable time. Means I've seen one person who I initially thought was tennis elbow. I never thought, because we had done an X-ray, it was perfectly all right. I always used to think it is a tennis elbow, and there was some pains and aches always happening to that lady. She was an ultrasound, this is an ultrasonologist. Then we did a CT scan and we found a lot of changes which had happened in form of hypertrophy which was happening on the side.
So the similar question, Sudhir.
Yeah.
Sir, we'll keep the
Similar question on this heterotropic ossification. Do you use indomethacin for 3 months post-operatively after TDR or any other thing, any other modalities? Just this was my question.
No, we don't use indomethacin.
It was a routine for us to use for any hip replacement always when we were doing. But we are not doing it for cervical disc replacement, and we have seen some amount of hypertrophic things, loss of movement. Not all patients are moving. We see it's a costly affair to get a fusion done by ADR.
If your neck is moving too much and your job is to bend your neck and do the work, then it is a problem to do it. It's not a good idea. Yeah.
Thank you, Doctor. I think, sir, we discuss at the end of the session. We will discuss at the end of the session. Lastly, after completing all the cases, we will discuss. No, we will continue discussion, no problem. Yeah, now request Dr. Jayesh, endoscopy in cervical myelopathy.
Respected chairperson. So I just changed the topic to endoscopic decompression, the expanding horizon. You can do from here, no? Okay. I don't have, I have given. I have given.
I would like welcome Dr. Yogendra Bhatt. He is going to speak on rethinking cervical myelopathy. Is decompression overemphasized and fixation underutilized?
Good evening, everybody. I am talking about little bit controversial topic, rethinking cervical myelopathy, where I believe the decompression is overuse and the fixation is underuse. Slide there. Okay. So there are two models. One is we always do plumbing and carpentry model to decompress the stenotic spine. So most of the time we are treating the effect of the disease rather than underlying contributing factors. So we should think of instability. Now, in the coming slide, I'll try to point out why instability is important. So, there are two models. One is plumbing model, where you focus on this canal narrowing, and when there is a disc bulge, you remove disc. When there is ossification of PLL, you remove the PLL. Means all is decompressive problem. So it is not a tightness in the canal is important. It is now you should think of the biochemical aspect of the spinal cord. When there is a pathological movement at lower vertebra and C1, C2, it can cause significant cervical myelopathy. So we are in a recent, when we are talking about the prophylactic surgery, we should switch over from the plumbing model to instability model. So now in couple of slides, I'll try to make convince, and it is quite interesting, being a neurosurgeon in a spine conference, I am talking about the fixation rather than decompression. So we need to make the spine quieter, not wider. So why this instability is very important? We see lots of patients when there is a significant stenosis in a MRI, but patient is walking. On the other side, patient is quite symptomatic and MRI is absolutely normal. So apart from compression, that is something, instability is causing a significant problem to the cord. So there is one patient where there is significant pressure, but patient is walking. We see another patient has MRI is absolutely normal. I am talking the static MRI, not dynamic MRI. When patient will be morbid. So static compression is not fully explain the pathogenesis of cervical myelopathy. So we must think always biomechanic of the spine rather than just pure compression. So what is missing? This is another patient where there is a significant pressure at 5-6 level, but the cord edema at a C4 level. So ideally, when there is a pressure on the C5-6, the cord edema has to be on the 5-6 level, not at 3-4 level. So micro movement at the cervical spine cause significant pressure and cause the myelopathy. So we see lots of patients who had a pre-existing cervical disc disease, and we met with an accident. They come with significant clinical symptoms which will never explain by the MRI. So it is because of when there is a trauma, the facet cause significant searing injury to the cord, which leads to cord edema, and patient will end up with significant profound neurological deficits. So we should think while treating the multi-level stenosis, particularly when there is OPL, we do lots of decompression laminectomy. If the compression is the problem, the patient should improve. But patient, most of the time, we see patient either deteriorate or remain static. So most of studies also indicate that apart from the compression, dynamic element also influence the disease progression. So does we do the decompression not properly? So by traditional decompression, laminectomy or corpectomy, the cord can expand, it can relieve the pressure, but it leaves a mechanical hammer on the cord, which causes persistent pressure on the cord, and patient will not improve or patient may deteriorate. So what is missing? So it is the instability. Before the instability, there is a micro motion at lower vertebra and upper vertebra, which cumulative cause the cord to damage. So micro motion at lower cervical spine and C1, C2 will cause significant damage to the cord. So spine instability can be because of ligamentum laxity or facet incompetition, which can cause axonal injury and microvascular decompression. So whatever we see the patient in a terminal stage is not, it is an end result because of cumulative occult motion. So micro motion happen at both level, at lower vertebra as well as C1, C2 also. when there is a flexion of a lower vertebra, it is called anterior translation of C1 over C2. And when there is extension, there is a posterior translation of C1, C2. So because of this, there is repetitive cord ischemia, there is an alteration of CSF dynamic, the patient will end up with some serings formation, and we should try, identify the patient on that reversible phase. So it is not the mechanical pressure, but it is the instability at the lower spine will cause a significant problem. So there is a concept called central biomechanical hypothesis. When there is a micro motion at C1, C2, which will cause significant hammering effect on the cervical cord. So there is a concept called neural rest. When you fix the C1, C2, the cord have a recovery from this micro motion, and patient will have a significant improvement in neural deficits. So why C1, C2 is important? Because God has given the concept, polarity concept. Every zone is alternate by stability and mobility. At C1, C2, it's significantly mobile joint, followed by the zone of stability. So out of total rotation, 50% of C1, C2 rotation happens at C1, C2 level, because C1, C2 does not have any disc. It depends on all ligaments. So any laxity of the ligament will end up with significant deficits, and there will be a hammering on the cervical cord. So we always see the static MRI, which will always normal in an early phase. We should always see the dynamic MRI. The static MRI is snapshot when car is stopped with the traffic signal. So we should always get a dynamic MRI, particularly in flexion extension and right and lateral rotation. So static MRI is like a car sitting on the red light. We never tells how the engine is working. While the dynamic MRI is when car gets maximum speed, then you can see the noise. So always there are the criteria for defining occult C1, C2 instability. These are the criteria. If the C1, C2 rotation is more than 45 degree, if there is asymmetry between 8 degree, then you can conclude it is a occult C1, C2. You can get dynamic MRI, particularly DTI image. When there is a loss of DTI, then patient can be aware. I will take more time because I have created controversy. So it will, at least I will try to solve the controversy. So this ticking is irritating me. So why C1, C2 has to be fixed? It is the apex. So Gujarati માં કહેવાય છે કે જ્યારે શિવ તાંડવ કરે તો શિવ ભગવાનને બંધ અને પૂજા કરવી પડે. It is like that. When you fix the C1, C2, you will have a cord have a neural rest. So patient will improve from hearing deficits. So when C1, C2 central instability associated with this pathology, like OPL, so C1, C2 being a very mobile segment, it acts as a lever, and against that thickened OPL, the cord gets stretched. When you have clipal fail, there is a two fixed joint where the cord, because of central instability, cord gets damaged. Similarly, when there is a fracture around the CV junction, particularly C1, C2, there will be a disturbance of hydrodynamic pump, which will cause significant deficits. So how to detect the patient with early myelopathy? So in a normal physiology, the upper cervical cord has a GPS for this gate pattern, proprioceptive receptor. So patient will start ataxia, initially ataxia in an uneven position. Otherwise he is walking normally. Patient will localize headache, and there will be autonomic dysfunction. Patient will have giddiness on getting up from bed in a flexion. Sometimes I have a patient where vertebral artery was trapped. Patient was playing cricket. During playing the cricket, the vertebral artery was trapped in a C1, C2 joint. Patient ended with cerebellar infarct, and during this dynamic image, we can find out that the vertebral artery was trapped, and we have released the vertebral artery, and patient is improved. So it is, you have eagle eye on view where is the problem. So we should find out the hidden villain. So it is basically micro movement, microtoma of the cord, and ischemia. Each cumulative leads to progressive myelopathy. So whatever we see always a static MRI, but we never see what cervical cord has gone through the multiple insult. So when there is a significant micromobility and there is instability, the cord get different fold. When you compare the natural history of the cervical myelopathy, it is always step lateral feather. So there are different tier. Tier 1, it is where there is cord is normal, cord is edematous. There is no irreversible damage. In that tier, if the patient has a clumsy hand, the power will be absolutely normal. But patient will difficulty in doing the fine movement. He cannot button, he cannot do proper signature. When patient have a positive Lermite sign, and as I already told, when patient is ataxia, this is a classical signs, the cord is pinching at the C1, C2 joint. So you should get dynamic study, not static MRI. Then comes the second stage is a transitional stage, where reflex are exaggerated, where neurologists can pick up the patient has cervical myelopathy. And then patient comes from green zone to red zone, where patient have a significant deficit, and cord will be edematous and damaged, from which is difficult to remove. We usually operate on a dead cord, not live cord. So these are tier. We should intervene tier 1 and tier 2. If you operate on late on end stage, we should not wait when we are talking about the prophylactic neurosurgery and spine surgery to spinal cord to become dead.
Yogendra bhai, please summarize your thinking.
These are the cases we have operated. I am talking about the few cases. The pure instability. The patient has middle-aged male patient has clawing of upper limb, difficulty in walking. He was bedridden. He was worked up by everybody. Neurologist has referred me. He had undergone every investigation, but he was not able to. The MRI was normal. So based on a patient was known case of seizure. So he has a repeated history of fall. So I think probably this is a C1, C2 instability. So with risk, I have explained the patient. We should give the traction. We have given the traction for 2 days. Patient has improved markedly. He immediately asked me the surgery. And Saturday evening, patient asked me the surgery. This is the dynamic study where there is a little bit tilt over C1 of the C2. Video batao. Video. I can see how the C1 is mobile. नहीं था तो. Video batao खाली. I did C1, C2 fixation. I did small for, this is the position of C1 in drop. Significant movement. This is the patient. The patient is from Bihar. This is immediate post-op. This is the second patient. Patient ended up with ataxia and clawing. There was a little bit instability. I did C1, C2 fixation. So when patient comes with clawing, with ataxia and repeated history of fall, you should think of central C1, C2 instability. So give a trial, traction of a trial. If patient improved, then patient himself will ask for the surgery. So this is a patient with C1, C2 clipal fall. Patient has a pre-existing clipal fall. He has fell down on the ground and end up with significant cord edema because, with associated multiple. So instead of doing discectomy, I did C1, C2 fixation with multiple transfacet screw fixation with bilateral microscopic laminectomy, not laminectomy. This is a patient on follow-up 15 days. This is another patient had a significant cord edema with existing disc. Since the canal was narrow, cord edema, so I need to do both anterior decompression, posterior decompression, and anterior and posterior. So fixation has to be proportional to decompression. So I did C1, C2 plating and with transfacet fixation. So another patient with high-grade C3, C4 lysis, subtle trauma, patient hand up with quadriplegia. In this patient was clinically unstable. So I not did C1, C2, but on 4th post-op day, you can see the significant cord edema, and patient has died because of respiratory infection. So when you exclude the C1, C2, patient will have lots of complication. That is what I believe.
Yogesh bhai, sorry, please, summary.
This is another patient with multiple. This is a multiple. So I believe the younger surgeon always see the bulge, disc and all this, and they try to make the whatever the canal is larger. But mature surgeon can identify the swag on the spine and try to make the spine quieter. So not every compressed spinal cord require a decompression, but every unstable spine requires stabilization. So from decade we have done lots of decompression, but we have leave the destructive searing engine running, which cause significant deficit to the patient. So I believe degeneration, as Dr. Goel sir believe, degeneration is an adaptation like airbag. It should be taken as a, thank you.
Thank you, Yogesh bhai. I request Dr. Mikeson Mirand, kinematics MRI cervical spine.
Can I just say something? Sir, please, we need to stick to time. We cannot keep
No,
on
it's okay.
overshooting the time that is allotted.
It's okay for
We need to tell that to each and every person who is going onto the stage. We have been doing this for last 10, 15 years. Everybody needs to stick to time, please.
Jayesh, it's okay? Ready? Yeah, okay. So Dr. Jayesh Sardhara speaking on endoscopy in cervical myelopathy.
It's going to take time. We can have another lecture then.
Where is the
Sorry for inconvenience. Respected Chairperson, good evening. Of course, I will try to stick with the time if it works well.
Mike's in.
Okay. So, this is about MISs, and of course, we should start with the lumbar spine, mini open technique, tubular technique, endoscopic. The important thing, my part of the talk is cervical comes later in the endoscopy, and there are some reason behind that. Would like to finish why it comes later, and it's not so much hard to achieve the cervical endoscopy, particularly both for radiculopathy and myelopathy. Look at this patient, 33-year male patient, C6 radiculopathy, and this is the C5, C6 young patient. You see this classical right side C6 radiculopathy. Now we are debating, what kind of surgical option we would like to offer. If you do the fusion surgery, yes, but still, it's a gold standard, adjacent segment disease 2.5%. Why not we are offering the motion preserving surgery? We have discussed about the ADR, again, the question of heterogenic ossification. Why not only endoscopic foraminotomy, particularly if it is suitable for this kind of options? Like, look at this case, particularly single level unilateral foraminal soft disc, unilateral hard disc on one side, young patient, radicular pain more than the neck pain. Yes, for canal stenosis, 3 level above, it's possible. Particularly, there is also the anterior and posterior decompression. I'm not saying that in all the cervical canal stenosis, we should go for endoscopic decompression. But where the posterior approach is indicated, endoscopic decompression is a very, very nice alternative with very good outcome. Single small unilateral cervical IDM, yes, it's a good approach. Some important bony landmarks, the V point. V point, where the two lamina unite the facet joint. The idea is to open the foramen. For that, you make this U into V. For that, 1/3 of upper lamina, 1/3 of lower lamina, and approximately 10 to 20% of facet supposed to drill. The 50% on one side is okay, will not cause instability. Now, what if you are dealing with the cervical stenosis? 2 level. 1 half lamina, 1 full lamina, that's 1.5. For 3 level, 2 adjacent half lamina and 1 full lamina. This is supposed to be decompressed. Now what makes the cervical endoscopy different from lumbar endoscopy? In cervical spine, the root exits from 1 level above the level of pedicle. Now that's make a difference. While you're doing the lumbar endoscopy, your nerve root is going away from you. Those who are beginning this spine endoscopy, please understood, once you open the foramen, nerve root is coming toward you. Nerve root is coming towards you. That's the major difference people are doing while learning the endoscopy. Second thing, the vertebral artery. You always miss that thing. Vertebral artery is exactly lying at the cervical laminofasciate point. So if you are lateral and your biopsy point is lateral to this point, you always keep this in mind, you will end up in the vertebral artery. This very, very two important point, please keep in the mind. Now this is very, very important. A lot of studies says this. If you go from C2 to C4, the V point you will get exactly at the nerve root crossing. It means exactly at the laminofasciate joint. But you go down, C5, C6, C7, once you open the foramina, you will find the dura but not the nerve root. You have to go maybe 60%, you have to go maybe 70% and all, because with the age it's variable. What is the pre-op checklist? Very, very important. One, of course, as I said, clinical. Neck pain supposed to be less compared to the radicular pain. Young patient, no bilateral pain. Very nice candidate for spine endoscopy. This is very important. Always go for spine instability. If there is a spine instability, patient would have
neck pain more than the radicular pain, on the long run, your foraminotome will going to fail. That's not on my personal experience, but also literature says that. Please rule out this spine instability. If you are beginning, the first 40 cases, check for the hard disk. It's very difficult to drill the osteophytes, particularly if you are learning. There will be a lot of hemorrhage, you will stuck up and you may end up with the open spine surgery. Third thing, look for the migrated disc. You cannot retract the cord in the cervical spine. It's difficult to find out the fragment, particularly at the beginning the cervical spine endoscopy. So don't choose the fragmented or migrated in the disc in the corner, plain cases. Now it's very important. If you are dealing with a tight canal with the foraminal compression, you have to decompress first all the canal and then you go to the foramen. Otherwise, your cord will compress on the opposite side of the lamina. Patient will end up with a contralateral weakness. That's usually happen in one or two. My own complication is that. So always I learn that first open the canal in such case. Sorry, I running fast. The basic endoscopy set which we are using in the lumbar spine, Revo interlaminar, I use in the cervical spine. I use the stenoscope for all the cervical spine cases. Other system, if you have a Destando, yes, it's useful. I started with things with a Destando, now I convert to the interlaminar endoscopy. Two things which make it different from the lumbar endoscopy. If it is a water-based system, always saline is supposed to be less than 40 degree. First of my two cases, I have kept 60 and 70 millimeter of mercury pressure with the water. Patient will end up with a weakness. And then I realized, I talked with the Sukumar, my good friend, and he suggested me, if you are working on the cervical spine, dorsal spine, your saline flow supposed to be at the shoulder or the head. Never use the water pump. Bipolar diathermy is supposed to be less than 20 because you are directly working on the root, very tight canal. Once you reach the dura, make it less than 20, we are doing same in the microscopy, right? The same thing. Position, same. Simple, neutral if you are dealing with the canal stenosis, and for radiculopathy, you should flex the neck so that your foramen will open and less ponytailing is required. Where you land up, you see in the C-arm, AP is always better than lateral view if you are dealing with the C6 and C7. C6 followed by, it's always overlap with the shoulder. So in the lateral view, it will not going to help. Always use AP view, you start with the T1 first, then go above, you count above. In the AP will be help. Where you land? Yeah. So this is the area, the V point, we can see the V point exactly. This is your landmarks, laminofasciate point. Okay, so start with the first dilator, always under the C-arm, laminofasciate point. You dilate, you always rotate your dilators, you feel the bone. Now it's very important. With the first dilator, you may enter to the interlaminar space. The case is not unusual. So this supposed to be over the lamina. The landing point is always the lamina, not the facet joint, because if you are targeting the V point, you may end up in the damaging the cord. So land up over the lamina, not in the V point. Then you start at the V point. So once you do that, this is the incision. You may require only 5 millimeter incision. Now how it works? Can we fast forward from there because I can't see the. Okay. No, I can do, if I can do here, then otherwise the time will be. Can I see the screen? Sorry. But I can force fast forward from here. I can't do fast forward from here, so it will be long. Okay, so escape करके करो so I can show them with the video. But वहाँ पे नहीं दिख रहा है. Okay, let me conclude. sorry, because of I can't fast forward, it will lack of the time. I will directly conclude. So these are the cases. Right side radiculopathy, we decompress. This is classical case of radiculopathy. Yes, for actually I prepared a step-by-step technique for all the youngsters, but unfortunately not working. So anterior and posterior compression, this kind of cases which there is a severe anterior as well as posterior compression. If the posterior compression is more, by the single level incision, you can decompress the lamina at the 3 level. And because you are decompressing up to the spinous process and you just undermining it, you're supposed to see the lateral border of the canal. The result is good, like you can see in this case. Sorry. Yeah, this is a post-op, you can see this. So you are decompressed from the posterior, there's a post-op, you can see the CSM on both the sides. It's just a single case. I have done maybe more than 60 cases of cervical spinal myelopathy, and I have realized what are the indications in the cervical spinal myelopathy in my experience. Number one, patient who is already operated for SCDF or an anterior compression, anterior fixation, and then he again come to you with the adjacent segment disease. These are the most important. Okay, so let me finish here. Anterior cervical myelopathy, where I do the endoscopic decompression. Number one, already operated anteriorly fused patient, again patient with adjacent segment disease. Fantastic patient, you can go from back, fresh incision, and you can decompress. This kind of patient, usually patient present with a radiculopathy, this is the best option. Number two, the canal compression is equal from anterior and posterior, both the side. Patient is elderly, doesn't require, it's not convinced with the anterior approach. Elderly patient, single 5 mm incision, you decompress well without any problem, and the long-term outcome is also much better. Third, where anterior compression is contraindicated. There are tracheostomy, there are some deformity in many cases in which anterior is decompressed. Posterior endoscopic approach is a very, very nice alternative. In radiculopathy, where the neck pain is less than the radicular pain, endoscopic decompression, posterior foraminotomy is wonderful. Thank you so much. And I'm really sorry for this technical nuance.
Excellent, excellent,
We'll take your
Jayesh.
questions later on.
Which scope do you use? At least for beginners, what do you say? It should be a small scope to begin with or a stenoscope directly?
Okay, so thank you, Dr. Ajay. So those who are beginning the endoscopy, if we are talking about the interlaminar, I would say for transforaminal, discoscope is better. For lumbar, discoscope is good. When we are talking about decompression, even for cervical, stenoscope is always better because the number 4 upcut we can use. We can use different instrument. We can use different drill particularly. So stenoscope is always better for dorsal and cervical.
But at the same time, I could twist the question to you this way. If to start with, whether you should do a laminoforaminotomy as your initial cases or directly jump to a myelopathy as your case?
Absolutely. First 30 case, I would stick to one side young patient unilateral radiculopathy. If I could have found a good result, if I well worth with the saline and all those things and endoscopy is set, then I will go for myelopathy.
And last one more, for white cord, which is the case which you'll say don't do by stenoscope?
For?
Which is the level of the myelopathy wherein you say don't operate by endoscopy because of water?
Because of water. That's a tricky question. Because of water, I would not say. Initially, for few cases, I find complication because of water flow. Then I again started without the pressure flow. I keep my saline at my shoulder level, and sometimes in case of hemostasis, I start to use, raise the height. Then I start to use a gel form. In the cervical spine, when there is hemorrhage in the endoscopy, we do in neurosurgery, right? Put a gel form inside the facet. The same, if you are using stenoscope, you just put a gel form inside the facet joint, you just hold the dissector there, and just 20 seconds it will stop. It's a work magically.
Anyway, thank you, doctor. Now I am waiting for Mikeson. It's a long time.
Good evening, everyone. I'm Dr. Mikeson. I'll be presenting on cervical kinematic MRI, and we conducted a study to find the efficacy of the kinematic MRI in our institution. So, what is the use case scenario for kinematic MRI? This is an example case, a 73-year-old female who was approximately Nuri grade 5. She was having severe myelopathic symptoms, and it increases when she sits and she stands, and reduces while lying down in supine. She was treated conservatively because of these radiographs, which was not showing any dangerous type of any stenosis, but she was treated conservatively for these radiographs for 3 months. Later, she came and we got a dynamic MRI for that patient, which clearly shows her neutral MRI, flexion MRI not revealing as much stenosis as the extension MRI, which gives a clear, detailed picture of the issue undergoing. Though there is chord intensity changes in the neutral and flexion MRI, the extension MRI shows the culprit causing the myelopathy. So background for this study is that degenerative cervical myelopathy has static and dynamic factors, and static factors like disc osteophyte complex and hypertrophied soft tissue are clearly evident in the normal MRIs. However, dynamic factors would require special MRI, like this kinematic MRI. This is a well-studied concept, and many articles are already written, which shows the utilization of kinematic MRI in these cases. So we also started the study with an aim to evaluate the clinical value that we get out of this kinematic MRI. How many new cases can we find out which are hidden because of neutral MRI? And we also try to find the changes in the hyperintensity of the chord signal changes with the kinematic MRI. So it's a retrospective study with 5 years study duration, and all patients who underwent kinematic MRI at our institute was analyzed. So what we did was this was our imaging protocol for the kinematic MRI, flexion and extension with the use of foams under the head or under the shoulder. Only the maximum comfortable position of the patient was taken. There was no any force. If the patient is comfortable in that position, that is the maximum extension. That much we have taken the MRI. Vitals are monitored to make sure there's no issues. Radiological evaluation, we did the stenosis grading as per the Mulle's classification. Changes in grade depending on the position of the patient neck was assessed. Hyperintense lesion, the amount of levels it increased and the grade of the lesion which increased was also assessed in the different position of the MRI, flexion and extension, using the Chen's classification. And appearance ratio of the cord, that is the number of compression levels which are newly detected, divided by the number of patients who we did not find any significant findings after the extension also was calculated. So total 369 patients in our study, and 1,845 disc levels are analyzed. The average patient age of the patient was 50 years. So this is our results section. In that number of 1,800 disc spaces, 653 disc spaces, approximately 35%, they showed some change of grade of stenosis from the neutral MRI to the extension MRI. And approximately 18% of the cases, they are converted from grade 0 in the neutral MRI to the grade 1, grade 0 or grade 1 in neutral MRI to grade 2 or grade 3 in the extension MRI. And 180 patients, 180 disc levels which are grade 0, grade 1 in neutral MRI converted to the highest grade, the grade 3 in the extension MRI. And 337 disc spaces with grade 0 or grade 1 or grade 2 converted to grade 3 on extension MRI. These are graphs showing the same. And the appearance ratio, which shows the number of newly detected levels also, we can see clearly here that the cord compression rate was mostly found in the C4-5, C5-6 level. However, the appearance ratio of the new stenosis levels were more in the C4-5 level. Comparing the number of patients, that is, instead of the disc spaces, if we compare the patient number, approximately 45% of the patients shows new increase in the grade in the kinematic MRI. Compared to the hyperintense lesions, when we are comparing the kinematic MRI shows more hyperintense lesions in the more clear, more defined and more clear lesions in the flexion MRI as compared to the neutral or extension MRI. This is one of the radiographs showing a more clear image of hyperintense lesion in the flexion MRI as compared to extension MRI. Thank you. This is my conclusion that cervical kinematic MRI may help surgeons plan the surgery, discuss the prognosis with the patient, and safeguard themselves from medical legal issues. Thank you.
Thank you, Michael. Just two suggestions. You have a standing MRI. Try
Yes,
flexion extension standing position. Second thing, amount of compression in dynamic MRI, flexion or extension, with maintained disc height and collapsed disc height. It makes any difference in not anterior or posterior compression if you continue in further study. Thank you very much. We call again the last lecture, Rohit, free and cervical pedicle screw fixation.
Sardhara sir, I'll just answer that question. Kinematic MRI.
Yeah,
While that time. અમે લોકો આ સર્વાઇકલ એમઆરઆઈ પહેલા ઓપન મશીનમાં કર્યા છે. ઇનફેક્ટ એના અંદર તો કાઇનેમેટિક મોમેન્ટના અંદર બી જોઈ શકાય. આ તો સ્ટેટિક છે. પહેલા કરતો હોય ને એને વિડીયો કાઢવું પડે અને દેખાય. પણ ધી થિંગ ઇઝ ધેટ ઇટ ઇઝ એ સ્લો ટેસ્લા મશીન. સો એના અંદરના કોર્ડ ચેન્જીસ તમને એપ્રિશિએટ ના થાય. કમ્પ્રેશન દેખાય છે. સો અવર ડિસિઝન ઇઝ મેડ ઓન કોર્ડ ચેન્જીસ, નોટ ઓન ધી કમ્પ્રેશન એક્ચ્યુઅલી.
Forward. A pointer. So, good evening everyone. I am the last man standing between you and the gala dinner, so I won't be taking your much time. So, I will be talking about freehand cervical pedicle screw insertion. So, it is like hitting a bullseye, because on the one side you have a vertebral artery and on the other side you have a cervical cord. So my talk is basically more of the technique based rather than on the data based. So it is on anatomy based, safe and reproducible technique for insertion of the cervical pedicle screws. Now why cervical pedicle screws? Because it is the strongest posterior cervical fixation method. On the evaluation of all the posterior cervical methods, starting from the wiring to the lateral mass, laminar screws, the pedicle screws are the strongest one, which was first described by the Dr. Abumi, and it gives a very good fixation in the posterior construct. So compared to the lateral mass, because lateral mass screws have a lower pull-out strength, it is having a limited correctional force, less effective in a kyphotic deformities, and as such the lateral mass are very small. So in a osteoporosis, it doesn't give good fixation, or sometimes a lateral mass also breaks. Compared to that, cervical pedicle screws give a 3-column fixation, greater rotational stability, and as well as superior construct rigidity, and that's why it is preferable whenever it is possible. So indications are like in any trauma cases, when there is a bifacet dislocation or unstable burst fracture, it can be used to reduce and fix it. Or in the case of a gross deformity like cervical kyphosis, as you can see in this case, the C2 is completely destroyed because of the infection, and the patient is osteoporotic. So that's why stabilization in the subaxial spine with the pedicle screw will give a better correction rather than putting just lateral mass screws. Tumors, infection, revision surgeries, or even in the cervicothoracic junctional deformity, it also gives a better correction force. So this is just one case example of a traumatic dislocation at C5-6, which was treated with the cervical pedicle screws. This is the another case example of the cervical compressive myelopathy, which was corrected on a lordosis in a extension view. So that's why only posterior fixation with the pedicle screws in a extension and decompression was done. This is the case of a cervicothoracic junctional kyphotic deformity due to Cox spine, As you can see, this was corrected just with the good fixation because we were able to put the C7 pedicle screws, and that's why it corrected from the 40 degree of kyphosis to 17 degree of the kyphosis, and that's why give a good decompression. So pedicle screw gives a better correctional force. It also has a very significant importance in the CV junction C1, C2 deformities also. As you can see, this is a case of basilar invagination, and with just a C2 screw, we were able to achieve a good correction. So when it should not be attempted. So whenever pedicle is very small or it is completely sclerosed, then it should not be attempted. As you can see in the upper part, there is only a cortical rim. There is no cancellous bone. So it should not be attempted. When it is destroyed completely with the tumor or the infection, then also it should not be attempted. Vertebral artery anomalies, that should be kept in mind whenever you are planning, and CT angiography is must before planning the surgery. Severe rotational deformity, congenital malformation, all this deformity ideally should be avoided. So as you can see in this MRI, you can clearly see that on the right side there is a dominant vertebral artery. On the left side it is a very narrow non-dominant artery. So if you are putting a screw on a right side and if you damage the vertebral artery, then it can be a disaster. So these things should be kept in the mind. So now see the cervical pedicle anatomy. Generally its size increase as we go from up to down. Medial cortex is always thicker compared to the lateral cortex. So medial cortex breach is also more acceptable even if it is thicker, because on the lateral side there is a vertebral artery, so you have to be careful and do not have to breach the lateral cortex. And as I already told, CT angiography and assessment of the vertebral artery is very much important before doing this surgery. Now surgical landmarks. Professor Abumi first developed this technique, and he gives the clear identification of the entry point, that it should be a slightly lateral to the center of the articular mass and close to the inferior margin of the inferior articular process of the cranially adjacent vertebra. So if we divide a lateral mass into the 4 quadrant, as we do in a lateral mass screw insertion, if we divide it into the 4, then the upper and the outer part, at that point the entry of the pedicle screw should be done. And you should identify the cervical notch also, because it is just above the notch. The entry point is just above the notch. The medial angulation will be 25 to 45 degree. It varies in patient to patient, and you have to study it in preoperative CT scan and then only do it intraoperatively. So preoperative planning is very important. As you can see in this case example, CT angio was done preoperatively for the C1, C2 instability due to fracture, and as it was planned preoperatively, exactly it was executed into the OT, and we were able to put the screws very safely. So pedicle screws placed on CT workstation before entering the OR prevent any mishaps. So let's come to the technique. Patient is generally positioned in a neutral alignment. Excessive extension should be avoided. Fluoroscopy access should be there, and it should be either on the tongue or a Mayfield extension, or it can be done with a ring also. This is a short video of how the complete exposure is done and identification of all the part. The lateral mass, superior facet. So you can see this is the complete identification of the C4 lateral mass. So this is how the lateral mass is identified, and the entry point is just at this point where I am doing the cautery. That is the point from where the entry is taken. So it is very important if you are planning for cervical pedicle screws, because you have to take a 25 to 45 degree of the medial angle. So that's why your exposure should be enough lateral and big, so you can get that angle. So it should be that. All the lateral mass has been exposed on both the sides. Creating the entry point is generally done with the high-speed burr. You have to just remove the cortical cell. As on the identified entry point, we are just now removing the cortical cell. This is a small 2.5 mm burr. So I am drilling it also, and I am using it also as a probe, that I am not violating anywhere in any wall. And once I am sure enough that I have reached towards till the pedicle, then I will take and probe and shift to the drill. So this is how the entry point is made. So throughout the process, the feel of the hard bone is very important. So this is once the drilling is done, then the probing, And once you probe it, if you feel safe that all the walls are intact, then the drilling is started. You can use tap also, you can use a pointed probe also, whatever you are comfortable with. And you can continuously check it in the fluoroscopy. So once the drilling is done, then the screw insertion. So now the drilling has been completed, and now you can see that I can feel all the walls, all the medial, lateral, superior, inferior, and anterior, and then I will confirm the size of the screw. Generally, size is also determined pre-operatively in the CT scan, and this is a 26 mm length screw. Diameter is generally 3.5 to 4 mm, not bigger than that. Can be placed, and this is how the screw is inserted. So this is the technique of a freehand cervical pedicle screw insertion. So insertion should feel smooth without any excessive torque. So this is just a small video of that how the kyphotic spine of 8 degree corrected to almost 7 degree of a lordosis, and with the placement of the cervical pedicle screws at C3 to 6 level. So as you can see that all the disc has opened, and in all these cases I have done a complete laminectomy with laminoforaminotomy to decompress the roots also, otherwise to prevent a C5 palsy. So complication, lateral breach definitely will lead to vertebral artery injury, may lead to bleeding, stroke. Medial breach can lead to a cord injury. Whenever you are not possible to place the pedicle screw, then you should shift to the lateral mass or laminar screw, or skip that level, but never force it. Technology can be definitely useful in this, navigation, robotics, augmented reality, everything. There are patient-specific guides also which can also help us to put these screws, but yet anatomy remains the foundation for freehand screw insertion. So to take home message, it is the strongest posterior cervical fixation method, but preoperative CT planning is mandatory. It is anatomy driven, not fluoroscopy driven. Ball tip probing is the most important step throughout the procedure, and safety always supersedes the screw placement. This is with me, Dr. Abumi, the pioneer of cervical pedicle screw, and this was the case done by the master himself for the drop head syndrome when I was there. Thank you.
Thank you, Rohit. I think we are going behind 15 minutes late.
Yes.
We have a guest. I think we are not
थोड़ा
taking any
question तो
further
पूछो
discussion.
रोहित ने
Thank you. No, it's okay. It's okay.
Sudhir sir. Apu.
I have done, I think, 18 cases till now. I haven't injured any artery till now.
So one more further trick. When it is essential to put the pedicle screw, cervical, like you have to correct the deformity. You have to fix it short segment in trauma. You have to fix in C12 fixation and fusion. The angulation when you put the C2 pedicle screws is many times almost 45 degrees.
Yes.
In the mid-cervical spine, the angulation is very high. So, if you are not using the navigation and operating with the standard fluoroscopy, you are anyway going to use fluoroscopy a lot. Many times what happens that you want to make the 45-degree trajectory, but your lateral musculature and fascia will not allow you to
the angulation.
So either you have to extend the incision, you have to subperiosteally strip the facet capsules of the upper levels and lower levels, and that will end up with the problems later on. So at the point you prepare your drill hole, don't try to put your screw or owl from the same incision.
Yes, take the separate incision.
Make to have triangulation 2-3 centimeters away from your original incision, and then put the stab incision, dilate it, and pass your owl and screw from that trajectory. That will allow you to put the screw from that trajectory
in the correct
only
angulation, yes, sir.
in the correct possible way. and will definitely correct your purpose.
Thank you,
Yes.
Apurva. And you had, I did it
Thank you,
even
sir.
S1 also sometime.
Yes.
Thank you.
Thank you.
Thank you so much for an amazing session. Next, we have a very captivating performance from Mr. Sushil, who will be setting up for about 10-15 minutes. So we have about a 15-minute window for the break. Thank you.
Rohit, just to add one more thing, probably I didn't see you mentioning the key slot. So key slot is making a pilot hole which is bigger, which takes your entry nearer to the isthmus. And that is the safest thing what Abhumi told. So if you are closer to the isthmus, then you don't miss out and go medial or lateral both. So bigger slot earlier, and then you go towards the isthmus. So that is key slot.